Assalamualaikum. Hello.
Waalaikumsalam, Prof.
Okay, so semua sudah siap. Kita start pukul 2 kan. Habis pukul berapa?
Should be at 5.
At
But
5?
if
Kejap.
we finish early, can finish early.
Wah, usually your session sampai 3 jam ya?
Not usually.
Usually berapa jam?
2 is the maximum hours.
Ya, macam mana boleh konsentrasi sampai 3 jam sekali? Ya. Biasanya maksimum 2 jam aja kan? So, how many of you in the class? Berapa orang semua sekali ada dalam kelas ni? Hello,
35, Prof. 35.
35. Wah,
Yes.
very big class. Semua buat pediatrics ya?
Yes.
25. So that means kalau ada bedside teaching, 35 of you will go to the ward.
No, we divided into smaller groups.
I see. So some group pergi Temeloh ya, ke macam mana?
We don't sure about that yet.
So far you don't have any bedside teaching at all.
Yes, we don't have any.
What about year 5? Ada bedside teaching now?
We don't know about that.
I see. Last batch year 3 ada bedside teaching tak? Ada, tak tahu juga. Tak tahu ke?
Last year ada. Tapi this year because of COVID, so we are not sure.
Yalah, because of COVID lah. Tapi what about the last group? This is the first group ke? Or what? The first group of this session this year?
Yes.
You are the first year 3 group.
Yes.
Okay, and so this is your first posting is in pediatrics.
Yes.
All right, okay. And 35. Okay, so I teach in Masa as well, and year 3 memang online teaching. Year 5 there is some bedside teaching, but now dah tutup balik dah, right? So basically all of you are Malaysians. Malaysians.
Yes.
Yeah, okay. Right, because some of my Masa students, for example, some are in India, some in Qatar, some in Bangladesh. So we have different time zones. So this one is okay. And all of you are in Kuantan now, or some at home?
Some at home, Prof.
Okay. I don't like online teaching. Number one, because tak boleh draw, tak boleh ni, tak ada personal contact. And I don't know how to share slides and all that. So it's too much of hassle. So I don't do that. So basically it all depends on your slides, you know. So, and like I said, I don't like online teaching because the interaction is not that good. And sometimes, like many of you are not opening your camera, so I do not know whether I'm talking to just Idham and Rahimi and Najimi and Muhammad Zul. Dia lain just buka and then tutup. So ideally, it'd be nice kalau all of you buka, and especially those who are presenting, those who are talking, mesti buka compulsory. Yeah, those are talking, those are asking questions, those who are answering questions pun, ya, mesti buka. Yang lain tu, kalau boleh, bukalah supaya kita boleh berinteraksi kan. Nanti kan kalau jumpa tengah jalan, at least kenal. Ya, Idham, Assalamualaikum, Idham. Ya, selalu nampak dalam TV, dalam komputer. Okay, so how many people are presenting? Idham,
For the session, there will be 4 presenters.
4 presenters. So kalau seorang setengah jam, eloklah, kan? And I will comment most of the time after each slide because kalau nak tunggu habis semua, nanti kan semua orang tidur. So after each slide, kalau anything to comment, I will comment. Anything to ask, I will ask. I will not wait until all the speakers are finished. I will not even wait until one speaker is finished. Yeah. So after each slide, if there are anything to do. So hopefully insyaAllah kita habis pukul 4 kan, setengah jam soal. And I've been given this untuk marker, rubric for seminar presentation. So I have to do this on every student, ya. Okay, so kita boleh mulakan.
Okay, let me share my screen first.
All of you are Malaysians. or some foreigners?
Yeah, all of us are
All
Malaysian.
Malaysian. So semua tahu cakap Melayu ya? Okay. Alright.
Okay, can you guys see my screen?
Yes, we can see it.
Okay, thank you. So, inshallah, I will start now. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I am Muhammad Afi Idham bin Ismail, matric number 1817741.
Kenapa saya kena tulis metric number dalam uni lah? Tak payah kan? So tak payah. No need for you to mention your metric number lah.
Okay,
Because I don't have to write your metric number here.
okay. So, inshallah, for today's presentation, I will share with you guys regarding a disease which is known as leukemia. So,
Okay,
this
when you're talking about the seminar, you are the first presenter and there are 4 of you. So it is good that you tell us what you're going to talk on, leukemia. The second person is going to talk on whatever it is. So what is the second speaker going to talk on?
the second speaker gonna talk about lymphoma.
Lymphoma.
The next one
Yes.
is nephroblastoma, and after that is brain tumor in pediatrics.
Okay, so why are these topics, these cancers chosen?
Because it is the commonest case on oncology.
Okay, because in the past, when I give lecture to medical students on cancer, I will give a general picture because specific tumors, even postgraduate pun tak tahu most of them. Because you are not going to be an oncologist to treat brain tumor. You are not going to be an oncologist to treat lymphoma or brain tumor. So basically, just general principle of pediatric cancers, the incidence of pediatric cancers, why it is important, the staging system, what's the difference between pediatric cancer and adult cancer, what's the percentage cure of pediatric cancers, what is meant by cure, the definition of cure, what is the definition of relapse, how the diagnosis is made for each cancer, what are the tumor markers available in cancers. So that will better outcome, learning outcome, than knowing specific cancer. Tapi since you all dah prepare this and your syllabus is each cancer like this, we go ahead and do it. Yeah.
Okay.
But there's no need for you to remember too much detail. Yeah. Even MRCP and all that, some of these cancers, right? No questions are being asked. And even if cancer is taught in most medical school, it is taught in final year, not in the 3rd year. 3rd year, you are taught a common one first, like asthma, like thalassemia, all the important ones. Tapi tak apa, sebab IIUM advanced, kan, the student advanced, so lagi far ahead. Alright. So silakan, Itam.
Okay, this is the outlines for my presentation for today. We will talk about the incidents, the classifications, the etiology, the clinical features, the investigations, the staging, the principle of treatment, the outcome, the prognostic factors, and also the late effects of leukemia. So before we move further into our discussion for today,
What is the late effect of leukemia?
the complications actually.
So what are they?
There will be distal body organ infiltrations, hyperleukocytosis, and after treatment, there may be tumor lysis syndrome.
Those are not late effects.
Yeah.
Late effects are effects that's still there when the cancer has been cured, when the cancer is gone. Tumor lysis syndrome is not late effect. These are side effects of treatment, acute side effect of treatment. Late effect is after a patient is cured 5 years, 6 years, 7 years, 10 years in adulthood. So late effects, okay, I will explain more about what is meant by late effects. Right? There is no late effect of leukemia. The late effect of it is the late effect of treatment, late effect of radiotherapy, late effect of chemotherapy, which can damage the heart. Yeah, late effect of radiotherapy, which can cause growth hormone to come down. Yeah, which can cause short stature and so on. Yeah. but not late effect of leukemia. All right, okay.
Okay, before we go further into our discussion for today, we should know what is actually leukemia. Leukemia is actually a disease where there is an abnormal hyperproliferation of immature white blood cells. This immature white blood cell is known as blast cells, and when there is hyperproliferation of these blast cells, it will lead to bone marrow destruction. When there is bone marrow destruction, bone marrow is actually a place where the normal hematopoiesis process take place. And when there is destruction, then the normal cells that should be produced by the normal hematopoiesis process will also be depleted. And other than that, these blood cells is not only stay in the bone marrow, it can go and infiltrate and also invade other body organs.
Okay, let me just summarize that, okay? To make it easy for you. Can you go back to the slide? Okay, number one, it is not just white blood cell. Red blood cell, platelets and all that, okay? So the precursors of the red blood cell, you can have erythroblastic leukemia. You can have megakaryoblast leukemia. These are precursors of the platelets. So basically, it is hyperproliferation of immature blood cells, not just white blood cells. Okay? So number one is there is increase in proliferation, the main characteristic. Number two, there is no differentiation. Okay? Because the normal process is you proliferate, the blood cells proliferate first, and then proliferate, they differentiate into erythrocyte. They differentiate into thrombocytes. They differentiate into lymphocytes. So in leukemia, there is proliferation, but there is no differentiation. Macam, let's say, dalam dunia ni, there is proliferation of babies, but the babies do not grow up. So these are young human beings and do not differentiate, do not grow up. The adult doctors, adult clerk, adult lawyers, so there's no proliferation. And number three, there is no apoptosis. You know what is meant by apoptosis? They don't die. They don't have natural cell death. So dia membiak, dia berkembang, keep on dividing, they do not grow old and they do not die as well. So that is the problem. And then, like you said just now, like Idam said, it goes out of the marrow, spread somewhere else. One difference between leukemia and other cancers is that leukemia does not have a stage, whereas other cancers, like lymphoma, there's stage. When it comes out of the lymph node, it becomes stage 2, stage 3, stage 4. And then the kidneys also, they have stage, kidney cancer, but not leukemia. How many slides do you have it up?
24 or 25.
Okay. Students, if you want to interrupt, you want to ask questions, you can ask anytime because we're not going to have prolonged discussion after it finishes 25 slides. It's better that you interrupt now, anything that you don't understand. Okay. Yes.
Okay. Okay, now let's talk about the incidence of leukemia. So basically, from all of the malignancies that occur in children less than 15 years old, 31% of them have leukemia. And from that 31% of them, 77% actually have acute lymphoblastic leukemia. And followed by 11% have acute myeloid leukemia. And in addition to this, there is an article in the Stars newspaper in September 2018. It is stated that actually the average number of leukemia cases in children in Malaysia is about 400 cases per year, and this is actually quite alarming for us.
Okay. Is it alarming?
I think alarming.
Not alarming.
Not alarming. Okay.
90%, more than 90% of cancers occur in adults. Okay, and very small percentage of cancers occur in children. Yeah, So it's more alarming in adult. In fact, if I'm an oncologist, when I tell the parents that, oh, anak awak ada cancer, all of them terkejut. Budak pun boleh dapat cancer. So the incidence is low. Okay. The incidence, overall incidence of cancer is 100 per 1 million children. Whereas more than 95% of all cancers occur in adults. So why is it important? Why are we discussing about cancer, about leukemia?
Because they might cause relapse in the future.
Cause relapse in the future. They must be alive first to cause relapse in the future. If patient die, they cannot have relapse. So it is important because it is the commonest cause of disease death in children after 2 years old. Why is it called disease death? Because the commonest cause of death in children after 2 years old is accident, poisoning, trauma, okay? Not due to disease. The commonest cause of disease death in children in developed countries are cancers. Why do I say developed countries? Because developed countries, death due to infection, due to pneumonia, due to diarrheal disease is very, very low, okay? Because of the lifestyle, no overcrowding, because of antibiotics, because of personal hygiene. So that's why it is important. That's why we are learning about pediatric cancer. Because Malaysia is a developed country, isn't it? Not yet, not developed yet. Developing country. If you look at Malaysian statistics, cause of death in children, cancer death in children is way down below. Whereas death in adult, cancer is one of the top 3. Yeah? Top 3 or top 2, cardiovascular and cancer, even in Malaysia. But Malaysia, not yet. So this is wrong. 70% from the malignancies are 70% of leukemias. So 31% leukemia of all the blood cancers, and it's about 70% actually. 70% or 75% of all leukemias are ALL. AML is much higher, about 20%. Another 5% is CML. So ALL about 70 to 75, AML about 20%, and 5% CML. What is CML?
Chronic myeloid leukemia.
Yeah, chronic myeloid leukemia. How many types of chronic myeloid leukemia do you know? Alisa, how many times? Afiq, forgot your pathology already. Lukman, Zul macam DJ nampak. Hebat. Yeah, Zul.
There are 3 types, right, Prof?
Okay, what are the types?
Wait.
There are 2 types. I don't know whether, because I don't know much about adult type, but chronic. There's chronic granulocytic leukemia or chronic lymphocytic leukemia, same thing. And the other one is chronic myeloid leukemia. Chronic granulocytic leukemia ataupun chronic lymphocytic leukemia does not occur in children. No. Niche. But CML can occur in children. More common in adults. So only in pediatrics, only 5% of leukemia is due to CML. Okay? Right. Macam ni 3 jam pun tak habis.
Okay, this is actually the classifications the classifications of leukemia. So basically, leukemia can be further divided into either it is an acute condition or chronic condition. Leukemia also can be further divided into either it is come from the myeloid progenitor cells or lymphoid progenitor cells. So there are four major class of leukemia. The first one is the acute lymphoblastic leukemia, acute myeloid leukemia, chronic lymphoblastic leukemia, and also chronic myeloid leukemia. So I would like to tell you guys, yes. Yes.
Yeah, ada your slide tu. Chronic lymphoblastic, chronic, yeah, and chronic myeloid. So chronic, it's not chronic lymphoblastic, it's chronic lymphocytic.
Lymphocytic, chronic
It's
lymphocytic.
not because it's not blood cells, this mature lymphocytes. So chronic lymphocytic leukemia ataupun chronic. So macam ni, tak boleh jawab. Ada dalam your next slide lah. Tak baca punya kau. Okay, so this, like you say, acute lymphoblastic, acute leukemia major classification, because there are others as well. Yeah, but these are the two major classifications. Next.
Okay. So what actually causes leukemia? It has been stated that there are two big factors that contribute to the patient to have leukemia. The first one is the genetic conditions. If the patient has abnormality in their chromosome or in their genetic, then these children are more prone to get leukemia. The genetic conditions are Down syndrome, Fanconi anemia, Bloom syndrome, and the list goes on. And the next factors that contribute to the leukemia is actually the environmental factors. If the children have been exposed to radiation, the children have been exposed to any types of chemicals such as benzene, or the children have go through chemotherapy sessions by using chemotherapy drugs, then these children are actually more prone to get leukemia in comparison to the children who are not exposed yet. And in Nelson textbook, it is stated that if the children have been infected with Epstein-Barr virus before, then the children may be associated with B type of acute lymphoblastic leukemia.
Okay, so one thing you must remember is that these are not etiology, these are associated factors. When they have Down syndrome, doesn't mean that they have leukemia. Yeah, and when they have leukemia, doesn't mean that they have any one of these or any one of these factors and one of the factors. So these are associated factors. The etiology is unknown. Yeah, we don't know what causes it. All right.
Okay, now let us move to the clinical presentation.
Okay, we do not know what the etiology is, but we do know what the pathogenesis is. Now, almost all cancers, we know that there is genetic changes in the cancer cell itself. So this is somatic changes, somatic mutation in the cancer cells, not in the body. So sometimes you have germline mutation. Do you know what's the difference between germline mutation and somatic mutation? Anybody?
Germline mutation from the endoderm, ectoderm, and also mesoderm, right?
No. Germline mutation occurs right from the beginning, okay, after fertilization. So that means germline mutation, for example, Down syndrome, the mutation is in which chromosome? Chromosome 21. It is germline mutation. That means all the cells will have abnormal chromosome 21. If you look at the cells from the buccal smear, from the tissue, from where all, somatic mutation is mutation that acquired mutation. So there may be somatic mutation in the colon cell of the colon. And this mutation predispose the patient to cancer. So that's the pathogenesis. The cell divide, and when they divide, and then they proliferate, and then they differentiate. But during the process of proliferation or differentiation, one of the cells may undergo certain changes, sikit je silap, in the DNA. And this DNA will cause the cell to have the growth advantage. The cell will not die. The cell will continue to proliferate. So this mutation, which can occur in the somatic cell, somatic mutation, is the one that can cause cancer. Sometimes you need 2 mutations, sometimes you need 3 mutations. But there is mutation which make the cells different from other cells and will continue to divide, whereas other cells stop dividing and other cells become mature and die. These cells do not mature and they do not die. So this is the pathophysiology of cancer. Genetic changes, we give them growth advantage and they do not undergo apoptosis. They continue to divide, they do not differentiate. This is what's happening in leukemia, right? Okay.
Okay, now let us move into the clinical presentation of the patient with leukemia. So, like I have said earlier, there is an abnormal of proliferation of cells, of blood cells in the bone marrow. So there is the normal hematopoiesis process will be disrupted, and the number of cell, the normal cells will be reduced. So generally, when the patient comes, from the general inspection, we can see that this patient with leukemia looks malaise and anorexic. And also, the patient may present to us with signs and symptoms of anemia because reduce the number in red blood cells. So the patient may present with pallor and lethargy. The patient also may present with bleeding due to thrombocytopenia due to reduce in number of platelet. And the patient may present with bruises, epistaxis, petechiae. The patient also may present with concurrent infection due to reduce in number of white blood cells. And the patient may present with bone and also joint pain. And like what I have said earlier, these blood cells is not static in the bone marrow. It can infiltrate and invade other body organ. So in acute lymphoblastic leukemia, when we do palpation at the abdomen, we can notice that the patient has hepatosplenomegaly. When we do the palpation around the neck, we can notice that the patient have neck swelling, and it indicates lymphadenopathy. The blood cell also can go to the genicular area and cause testicular swelling, and the patient may complain with symptoms of CNS involvement if the blood cell has already invaded the central nervous system. The patient may tell us that they have headache, vomiting, and convulsions. In acute myeloid leukemia, the patients may present with gum hypertrophy, especially in the M4 or M5 type of acute myeloid leukemia. The patient also may present with DIVC, disseminated intravascular coagulation, that usually associated with M3 types of acute myeloid leukemia. The patient also may have chloromas and also subcutaneous nodules. Okay, so
you're going to show picture. Just go back. Relax lah, tak apa. Kita ada sampai pukul 6, right? And when you do full blood count of a patient with leukemia, with the white blood cell count, what does it show usually?
They usually will be decreased, normal, or increase. It varies.
Which one is more common?
Increase.
Increase is more common. So you say it's leukopenia.
Leukocytosis.
Okay, when you do full blood count, yes, the white blood cell may be 30,000, 50,000, 100,000 even. You may have hyperleukocytosis. But this increase is because of the blast, which the machine will count as white blood cell. But actually, they are immature cells. Most of those are immature cells. So they are not functional. So that's why they have infection. Right? So even though the white cell count are high, but they are immature, they are baby soldiers. They cannot fight infection. Because most of them are blasts. But it's true, if you do full blood count, sometimes it is low, sometimes it is normal, but most of them is high, and it's high because of the blast count. So what's chloromas?
Chloromas is actually a fat in the subcutaneous tissue.
Okay.
In the
Okay, that's infiltration of the leukemia cell into the subcutaneous tissue, right? Okay. And why do you put dot there under CNS involvement?
This is actually the example of the patient complaint when there is infiltration of blood cell into CNS.
Okay, sometimes it is asymptomatic. It is part of the workup for error. I'm sure you'll tell later. Include doing the lumbar puncture because CNS involvement may be asymptomatic. Yeah? And all these are painless. Yeah? Lymph node swelling is painless. Liver spleen swelling is painless. Testicular swelling is painless. So that's why when you see a patient with leukemia, you have to examine properly. Yeah, you have to examine the testes, for example, even though they do not complain of pain. Yeah, sometimes testes as big as a coconut pun, no pain also. Okay, thanks.
Okay, this is actually several pictures. The left side, the left upper side is actually a picture of
Ada pointer, can you use a pointer?
Okay.
Yeah.
Okay, this picture is actually a picture of petechiae due to thrombocytopenia. This is actually a picture of chloromas. This a picture of gum hypertrophy in M4 or M5 type of acute myeloid leukemia. And this picture is actually a picture of lymph adenopathy, neck swelling due to lymph adenopathy.
Okay, how do you recognize whether rash is petechiae or not?
Other than petechiae, there may be bruises.
No, what's the characteristic of a petechiae?
It is numerous in number.
No, measles rash also may be numerous in number. Anybody can answer?
Is it pinpoint bleeding?
Yeah, it is due to pinpoint bleeding. But how do you know this is pinpoint bleeding? How do you know this is petechiae? How do you know this is not measles rash?
When we press the bleed dia punya apa nama? The red will not disappear, will fade, and then after some second it will appear again.
It will not fade. It will fade or will not fade?
Will fade. I think so.
No, you're wrong.
Okay, thank you.
Why you thank me? You're wrong. I told you you're wrong. You should thank me when I tell you the answer. If I tell you I'm wrong, then there's no need for you to thank me. Okay, it is the opposite of what you say. In the petechiae, because of the bleeding under the skin, when you press, it will not fade. So this is very important for undergraduate, especially year 3. Yeah, to know whether it is petechiae rash or not. You see a reddish rash like that. If it is erythematous rash, then you press, it fades. So how do you press? See whether they fade or not. How? Zul, Muhammad Zul, Umaira, Rahimi. You press with the glass. You take off your chili butter, you press on it, and then you see that it doesn't disappear under the glass. Okay? Most people say press with the hand, and you press with your thumb. When you press your thumb, of course, the rashes will be under your thumb. You cannot see whether it disappears or not. So glass piece. When you go for your clinical exam, always bring a glass piece, just in case you get a patient with rash, and you want to test whether they blanch on pressure or not. Okay? Is this typical chloromas? Idam?
Yes, this typical chloromas.
Typical chloromas is described as greenish lesion. Ni daripada buku mana ni? Memang dia cakap this is chloroma.
This is from website.
And they say this is chloroma.
Yes.
It looks like an old bruise. But chloroma may change color, but usually chloroma is greenish in color. That's why it's called chloromas, because it comes from the word chlorophyll. Chlorophyll is green. So chloros means green, it's greenish in color. Right? Okay, thanks.
Okay, now we will go into investigation. So basically for investigation, there are 2 types, the diagnostic type and the staging type. So we will go into the diagnostic investigation first. So to diagnose leukemia, you can do full blood count and also peripheral blood film. And in full blood count, you can see there is actually anemia And the type of anemia that usually occur in leukemic patient is a normochromic normocytic type of anemia. And you can see there will be varies in the white blood cells, and like what Prof has said just now, usually there is an increase in white blood cells. You can also see there will be reduced in the number of the platelet. And in the peripheral blood film, you can see that there will be presentation of blood cells, and there also will be presentation of auroch cells that is specifically for acute myeloid leukemia. And after that, we can also do biochemical tests. And in biochemical tests, there will be an increase in lactate dehydrogenase and also increase in the uric acid. And we can also do bone marrow aspiration and trephine biopsy. In bone marrow aspiration, we can see that the blood cells, the blood cell is more than 20% of the bone marrow. And in trephine biopsy, we can see that there is an increase in cellularity in comparison to the normal person. If we suspect the patient with CNS involvement, then we can check their cerebrospinal fluid. There will be the presentation of blood cells in their CSF. And we can also do chest X-ray, radiography investigation, chest X-ray. When we look at the chest X-ray, there may be lytic bone lesion and also mediastinal mass that usually associated with T-type of acute lymphoblastic leukemia.
So what do you have to do to diagnose? What's the diagnostic test?
The diagnostic test is actually the peripheral blood film, bone marrow aspiration, and trephine biopsy, in my opinion.
So you have to do all the three.
Yes. To look for the blood cell.
The confirmatory test is bone marrow aspiration. Right? So when you present this, try to avoid to use the word can. We can do full blood count. Of course, we can do full blood count. We have modern hospital. We can do full blood count. Yeah, we can do bone marrow aspiration. We have the expertise. We can do. But the diagnostic investigation, okay, include number one, doing a full blood count. Yeah, this will helpful in making the diagnosis, but it is not diagnostic. Yeah, even though a patient got anemia, patient reduced platelet, yeah, does not confirm. Even if there is blast, also does not confirm. And some leukemia does not contain blast in PBF. So you must understand what is meant by confirmatory test. Confirmatory test usually is just one test which tell you, okay, if it is positive, it is leukemia. If it is negative, it is not leukemia. So which one is the confirmatory test?
The bone marrow aspiration.
Bone marrow aspiration, and you must have more than 20% blast. This diagnostic. Most books will say more than 25% blast for AML. But no, for ALL more than 25% blast, for AML more than 20%. If it is 10%, 15%, it is not diagnostic. Okay. So full blood count usually abnormal. They may have anemia, they may have low platelet, they may have high white blood cell. They may be blast, but not always there. Even if there is blast, you cannot say, oh, this is leukemia. There's no need to do bone marrow. That's not right. You have to do bone marrow. Yeah. And actually, whether the blast is present or not depend on white blood cell count. The higher the white blood cell count, like I said, most of the white blood cell count will be blast cells. Right? So usually you can see presence of blast in the blood count. So the most important thing is from the peripheral blood film. Yeah, you recognize blast from the peripheral blood film. Biochemical test, okay. LDH will tell you the tumor load. Uric acid is more for baseline for treatment, because when treatment, uric acid can go up. So biochemical test is need to help in the diagnosis, maybe not useful at all to help in the diagnosis, but more for you to monitor when you treat the patient. The urea may go up, right? There may be liver function abnormalities. So you want to do all that monitor. Bone marrow is the most important. CSF have to be done routinely in all patients with ALL because chances of having CNS leukemia is high. CML, there is no need to do routine CSF because that's not very common. Right? So the presence of even a single blast in the CSF plus more than 5 white blood cells in the CSF is diagnostic of CNS leukemia. Chest X-ray usually is not done routinely. If the patient comes with stridor and all that, you want to do chest X-ray to see whether there's a mediastinal or not.
Okay, this is actually a picture for blood cells in acute lymphoblastic leukemia. And on the right side, this is a picture of blood cells in acute myeloid leukemia. As you can see in the red circle, there is actually a presentation of our root cells.
So that's pathognomonic, yeah? Yeah, okay.
Okay, this
ALROD is pathognomonic of AML. Yeah.
Okay, for this slide is actually just to show you guys the difference between the hypercellular bone marrow and the normal bone marrow. As you can see in the left picture, there is numerous number of cells. So this is actually an increased cellularity in the bone marrow. Okay, for this slide, this is actually a chest X-ray for patient with T type of acute lymphoblastic leukemia. You can see in this red circle there is mediastinal mass. Okay, now let us move to the staging.
All right. So basically, when you do bone marrow, you do 4 things. Yeah. If you answer a question, for example, how do you investigate confirmed diagnosis of leukemia? You cannot say bone marrow alone. Because bone marrow is just a procedure, just like taking blood. Taking blood, venipuncture is a procedure. Bone marrow is a procedure. You say you want to do bone marrow, number 1, to look at the morphology. Morphology means form. So from morphology, you can tell it's hypercellular marrow, full of blasts, more than 25% blasts. This is what is mentioned by morphology. You see hypercellular many cells, most of them are blasts, and more than 35%. That makes the diagnosis of leukemia. So what's the next step? Idam?
The next step is
the bone marrow.
Bone marrow, 3' biopsy.
Okay, 3' biopsy you do together, right? Basically to get marrow specimen. Sometimes you do the marrow, sometimes it's all blood. Tak dapat. Sometimes dry type, tak keluar marrow. So you do 3' biopsy as a substitute. If you have a good bone marrow expression, refine is not that important anymore. Okay, so usually you do it. The next step, apart from morphology, is to recognize what type of leukemia it is, whether it is AML or ALL. Yeah, so how do you do that?
You can see that there is actually the our root cells presentation in acute myeloid leukemia.
Yeah, but not all of them will have ALL. Not all AML will have ALLs. So you do immunophenotyping. You know what is immunophenotyping? All the cells in our body will have markers, will have antigen on it, surface markers. Yeah, and you can tell by doing immunophenotyping, you recognize whether it is CD4 positive, CD20 positive, CD10 positive. This is AML or this is ALL. So you send this bone marrow expression for immunophenotyping. In the old days, you do cytochemical staining. You use all the stain and all that. So from this immunophenotyping, you can tell whether it is AML or ALL. And ALL you divide into B cell or T cell. And from immunophenotyping, you can tell whether it is B cell or T cell. And then the next thing is you can do molecular genetic. Again, help you to tell whether this is ALL or AML, whether it is B cell or T cell, but more importantly, it helps you to tell the prognosis. Okay, so these are the 3 steps. Okay, number 1 is cytology or morphology. Number 2 is immunophenotyping to recognize it. And number 3 is cytogenetic or molecular genetic. Yeah, okay.
Okay, now for staging investigation, like what Prof have said just now, we can do flow cytometry to look for immunological tumor markers to differentiate either it is myeloid type or lymphoblastic type of leukemia. And after that, we can do cytogenetic and molecular tests. This cytogenetic and molecular test will determine either the patient with leukemia will have good or poor prognosis.
Okay, so staging. Kalau ada CD10 ni, what stage?
I found an answer.
Kalau
CD10.
CD19 tu what stage of leukemia? Damn, I told you from the beginning that there is no staging in leukemia.
Yes, the staging, the staging.
So this is, you want to know the type of leukemia. So this immunophenotyping. This is called immunophenotyping, and you do this by flow cytometry. Flow cytometry, you collect all the blood cells, and then you state, you do immunophenotyping them. Then you can tell whether CD10 is positive, CD19 positive, and this will tell you the type of leukemia, what type of ALL, and whether it is ALL or AML. And cytochemistry, I told you also, it tells you the type of leukemia. For example, if there is 922, then it is ALL. If it is 1517, this is M3, like what I said just now. And it will tell you the prognosis as well. ALL with 922 translocation, Philadelphia chromosome, poor prognosis. Okay, so this is the second part, morphology, immunophenotyping by flow cytometry, and cytogenetic, molecular cytogenetic. Yes, it's not staging. It's more detailed bone marrow analysis. Yes.
Okay, next. This is not staging. This is actually to show the specific subtype. So actually, like what Prof have said just now, there is no staging in leukemia because this cancer originates from the bone marrow and it disseminates through the body through the blood vessels, and it will not form any single solid mass. Therefore, it is not required. It is not required for TNM staging like in other cancer. So as you can see, after we do immunophenotype classifications, we can know either it is T type or B type. And also there is French, American, British FAB classification, L1, L2, and L3. I would like to highlight this L1 type of acute lymphoblastic leukemia, as this type of leukemia has good prognosis.
Tak apalah, tak saya, tak payah. Idam, where are you from?
I am from Kuala Lumpur.
Oh. No need lah.
No need.
Kelihatan kata tak payah, tak saya. Yeah, because this is not used anymore. This is old classification. Yeah, you don't use L1, L2, L3 anymore. Yeah, historical.
Okay, this is the subtype for acute myeloid leukemia according to World Health Organization. So
This one you have to memorize
okay.
all of them. If you cannot memorize, you cannot pass the exam. Betul lah, Idam? Tak betul. Why you want to memorize all this? Yeah, no need. Okay. So
Okay.
there is okay.
Okay, this is for subtype for acute myeloid leukemia according to French, American, British system. And I would like to highlight the M6.
Tak payah highlight lah. It's not important. Because you don't use FAB classification anymore. You just call it by name. For example, M3, you just call it APML, acute pulmonary. If it is megacoloblastic, you call it megacoloblastic. Yeah. So FAB, yeah. Why FAB was so fancy about French? French are anti-Muslim. Cancel them. American also now going bankrupt. Cancel British. Yeah. No need. Yeah.
Okay.
All you need to know is the type, yeah, especially this one, acute pulmonary, because this is This is what you say, yang you mentioned DIC, this one that can cause DIC. But now it does not cause DIC anymore with a special treatment. Yeah.
Okay.
M7 omega claudoplastic occurs more commonly in patients with Down syndrome. Right. So again, this is not staging, huh?
Okay.
Well, no, not staging. These are different subtypes.
Okay, now let us move to the principle of treatment. So before we start treating the blood cell itself, we need to treat the sign and symptoms that the patient presented with. If the patient presented with sign and symptoms of anemia, then we need to treat the anemia first. If the patient present with concurrent infection, then we need to treat the infection. If the patient present with bleeding due to thrombocytopenia, then we need to do platelet transfusion to them. After we have finished with treating the sign and symptoms that the patient presented with, we need to start treating the blood cells. The first phase in treating the blood cells is the remission induction phase.
Why you want to treat the blood cell? The blood cell sakit ke?
Eradicate the blood cells.
You don't treat the blood cell. You treat orang sakit. Yeah? Okay, so that tells you the principle of treatment. Number one is supportive treatment. Good supportive treatment, treating the infection, treating the anemia, treating the thrombocytopenia, because this can occur even after treatment. Yeah, during treatment itself can occur after you started treatment, because the treatment can cause myelosuppression. So one principle is supportive treatment is very important. Number two is curative treatment. This is called curative treatment. You want to cure the patient. Number three, sometimes that fails. Then you want to give palliative treatment. So principle of treatment of cancers, there are four things. Number one is curative. Cannot cure, you give palliative. And during this, you have to give supportive treatment during palliative and curative. And what you need to know about the principle, this is curative treatment they're talking about. Yeah. So the supportive treatment. So can you talk about curative treatment now? Curative treatment means induction, consolidation, CNS, prophylaxis, and maintenance. Okay, you want to read what you write?
Okay. The first step in the curative treatment is for remission induction. In this phase, it will kill most tumor cells rapidly with combination therapy for 4 weeks. And after that, we need to ensure that the blood cells do not infiltrate the central nervous system. Therefore, we need to give them methotrexate to prevent the blood cells from entering the central nervous system. The next phase is the consolidation phase. In this phase, blocks of intensive chemotherapy is given to maintain remission and to reduce the tumor burden. And the last phase is the maintenance phase. In this maintenance phase, we give them chemotherapy for 2 to 3 years to prevent any relapse.
Okay, so the principle of treatment, number one, it is multi-phases. You only need to know multi-phases. That's nothing for you to hafal. Multi-phases. And then multi-drugs. Macam induction, sometimes you have to use 4 drugs. Consolidation, 4 drugs, 4 different drugs. CNS prophylaxis, maybe 2 drugs. Maintenance, another 3 drugs. So it is multi-phases, they'll give multi-drugs treatment, and then it is prolonged. Yeah, for 2 years, at least 2 years. This is for ALL. For AML, the treatment is very short, much shorter, but it's still multi-drugs. It doesn't have phases like this. This is phases is only for ALL. So for AML, it's only about 2 months of treatment. Most important thing is remission induction. What is meant by remission?
When the disease is absolute, when the blood cell is eradicated, then it is remission.
So what do you mean by blood cell eradicated?
There is the number of blood cells will be reduced.
What number? Where? Reduce or eradicate? These are 2 different things.
Eradicate?
Eradicate, I mean blood cell 0.
Yes.
Wan Ashraf. Ini mesti adik-beradik saya ni. Wan Ashraf. Anak buah. Wan Ashraf. What is meant by remission?
Remission and relapse. Remission.
Why you want to mention the word relapse? I say what is meant by remission. Nanti kan I tanya you, what is
Okay.
relapse? That dua become two questions. From one question become two questions.
Remission is when the disease start to subside.
Start to subside. When they start to subside, bila agaknya? After one day of treatment, they start to subside already.
I don't sure that.
Nurul Ain.
Yes, yes, Prof. I believe remission is when we are able to eradicate the cancer cells, right? So there are decreased amount of cancer cells inside our patient. So that's what it means by remission.
I also believe the same thing as you lah. But what number? Said numbers reduced. You must be specific. Anything at all must be specific. Nephrotic syndrome, what is meant by remission? Everything also will have to be specific. Remission means that there is all the signs and symptoms of leukemia may no longer be there. No more lymph nodes, no more hepatosplenomegaly, no more bone pain. The hematological parameters become normal. No more thrombocytopenia, no more increase or decrease in white cell, the hemoglobin become normal. And most importantly, you have to do bone marrow again. And the bone marrow must be less than 5% blast. Okay? So if liver spleen disappears, blood count is normal, but the bone marrow shows 6% blast or 7% blast, then it is still not in remission. Yeah? With remission induction, for 4 weeks, some protocol gives 6 weeks. The chances of going to remission is very high, more than 95% going to remission. Those that do not go into remission is considered as bad prognosis, and they may require bone marrow transplant for treatment. So this is very important. Remission induction is very important. Given for 4-6 weeks, at the end, more than 95% will go into remission, in which case you continue with all the other treatment. If they do not go into remission, this is called resistant leukemia or refractory leukemia. Then you have to give more chemotherapy, including bone marrow transplant maybe. And the definition, the most important definition is less than 5% blast. The blast will have to be normocellular, not hypercellular anymore, and less than 5% blast. Okay. Next slide.
Okay. Now we will talk about the prognosis for acute lymphoblastic leukemia. For acute lymphoblastic leukemia, about 80% of the patients with acute lymphoblastic leukemia will cure. However, this is there are several factors that determine if the patient have good or poor prognosis. So if the patient come to us with low initial white cell count, if the patient is female and in between 2 to 10 years old, and it takes less than 4 weeks.
Yes.
It takes less than 4 weeks to remission, and the and the genetic abnormality involving translocation in the chromosome number 12 and 21, and if it is hyperdiploidy, and if it is L1 type of FAB, then the patient may have good prognosis. However, if the patient presented with high initial white cell count, if the patient is male, less than 2 years or more than 10 years, or it take more than 4 weeks to remission, and there are several type of chromosomal abnormalities, and if it is hypodiploidy, and if it involves the central nervous system, then the patient may have poor prognosis.
What do you mean by cure? You say cure rate is 80%. What do you mean by cure?
When we eradicate the blast cells in the bone marrow.
So your definition of cure and remission is the same. Tadi tanya remission, you kata eradicate the blood cell. The cure pun eradicate the blood cell. Alisa, what's the definition of cure? What is meant by cure?
Cure is like the patient won't have it anymore.
Won't have it anymore.
Yeah.
So what do you mean by that? Won't have anymore. So bila you declare that this patient, oh, you have been cured of leukemia. When the patient say, oh, I'm not going to have it anymore, I won't have it anymore, then it is considered cure.
Mm.
Cure in leukemia and in most cancers, most other cancers, is when the patient is in continuous remission for more than 5 years. So if patient has got leukemia in 1998, and then in year 2000, you still cannot have a cure yet because the remission is only 2 years. Yeah, so patients who have a leukemia in 1995 can be considered as cured only in year 2000. After 5 years, no relapse. Okay, then considered as cured. The patients got 1995 and got leukemia and then relapsed in 1999. The patient not been cured of leukemia because relapsed within 4 years. So can the patient be cured? Still can be cured with different treatment, but patient will be cured. You have to wait another 5 years after the relapse. Relapse in 1999. The patient go into remission and continue to be in remission, no second relapse. After 5 years, then patient is considered as cured. Okay? So prognosis, good prognosis. Why, Idam, your sexes are female, you give good prognosis, male, you give bad prognosis.
Because for incidence of leukemia, female is 1.2 per 1 male.
So because there are more doesn't mean that's more difficult to cure. It is believed because male has got testes. So they may have testicular relapse. That was what was believed initially in the beginning. But now it's not true anymore. Male and female have got the same prognosis now. Because the prognosis changes with treatment. Many years ago, 1960s, the female has better chance of cure than male. Maybe because male have got testes. So they may have testicular relapse. Another extra place to relapse. But now in year 20,000, in this century, doesn't make any difference anymore because the treatment has improved so much. One example is, okay, I live in Ipoh. 20 years ago, if I go by Japanese car to go to Ipoh, and my friend drive a Mercedes car, which one has better prognosis of arriving in Ipoh?
The car.
Which car? Mercedes lah.
Mercedes.
Because Japanese car maybe sampai tengah jalan, sampai ke Tanjung Malim dah rosak. Or everything broke down and all that. But now the technology is so good. Japanese technology has improved. So whether you go in Japanese car, you go in Proton, you go in Mercedes, the chances of getting Ipoh is much there. So similarly, leukemia nowadays, because the treatment is so good, some of the factors which last time were there, bad prognostic factors, for example, male, is not true anymore. Last time also when you are Negro, compared to the whites in America, Negro poorer prognosis, but now that's not true anymore. Okay? You know what is meant by hyperdiploidy and hypodiploidy?
The number of chromosome?
Yeah, the number of chromosomes in the cancer cells. How many chromosomes do we have? Normal cells, how many chromosomes?
23 pairs.
Huh?
23 pairs.
23 pairs.
22 autosomal and 1 sex related.
Okay. So 46 chromosomes. So hyperdiploidy, you do the chromosomes in the cancer cells and other, you find that they may have 50 chromosomes. Yeah, so that's good prognosis. And hyperdiploidy, instead of 46 chromosomes, they may have 40 chromosomes only in the cancer cells. Yeah, so this is hyperdiploidy poor prognosis. Okay. Ida, nasib baik your friend help you. You have to know. Yeah. Okay.
Okay, now for prognosis of the acute myeloid leukemia.
All right. Why is it important to know the prognosis right from the beginning? Can you go back to the last one? Why you want to know the prognosis?
To know is it the patient is curable or not, to ensure the patient life prolonged.
Okay, number one, you can tell the parents, okay, sorry to say it, he's only 1 year old, and on top of that, he's got 411 translocations, so get two bad prognosis. So his chance of cure is less than 50%. Or another patient come, oh, this is very good, he's 8 years old, white cell count is, and then it goes into remission, and so chance of cure is 90%. So number one. And number two, because the treatment for leukemia or most cancer, the treatment is stratified. Stratified ni maknanya according to the poor prognosis. So patient with bad prognosis, you treat more aggressively, you give more chemotherapy, more intensive chemotherapy. If they have good prognosis, you don't treat the same as bad prognosis because they are good prognosis. You give too much treatment, they will die of the side effects of treatment. They will have long-term side effects. So this is called stratification. You stratify the treatment according to the prognostic factor. And why you do that? Number one, because you want to achieve maximum cure. So bad prognosis, if you give the same treatment as good prognosis, you don't get cured. The bad prognosis, they require more treatment. And the good prognosis one, you give same treatment as the bad prognosis one, they have a lot of side effects because you give too much treatment. So the aim is maximum cure, which include for patients with bad prognosis and with minimum side effects, which can occur in patients with good prognosis if you give the same treatment as the patient with bad prognosis. Understand? All of you understand? One, Ashraf, understand? Okay, so another principle of cancer treatment is prognostic, is stratified treatment. In solid tumors, stage 4 is treated more aggressively than stage 3, than stage 2, than stage 1. This is you stratify according to prognosis because stage 4 has got worse prognosis, stage 1 good prognosis. So you stratify according to the prognosis. Yeah? Leukemia has got no staging, so the stratification is not according to the stage, but according to these prognostic factors. Okay.
Okay, this is actually the prognosis for acute myeloid leukemia. It is stated that about 60 to 70% of patients with acute myeloid leukemia will cure.
Okay, so
And this.
Yes, silakan.
Okay, and this prognosis number is actually will be determined either the patient adhere to the treatment or not. If the patient adhere to the treatment, then they will be cured.
Okay, tinggal berapa lagi slide? Okay, late effect.
Dua. Late effects.
Okay, these are not late effects. Okay, organ
yes.
infiltration is not late effect. This is the presentation. Bleeding and all that is not late effect. This is could be due to the disease itself. It could be due to treatment. Because when you give treatment, the treatment actually cannot recognize leukemia cells. The treatment that you give actually kill all the rapidly dividing cells. So leukemia cells are rapidly dividing. That's why they are infiltrating the marrow. And what's the next rapidly dividing cells in our body? The next one. What is the most rapidly dividing cells?
Epithelial.
The white blood cells, isn't it? The white blood cells. The lifespan of white blood cells is only about 3 to 4 days. So they keep dividing, otherwise then the one that die will not get replaced. So they keep dividing. The platelet count. Platelet, the lifespan of platelet is only about 7 days to 10 days. So that's why they are rapidly dividing. Otherwise, all of us will run out of platelet, normal people. So when you give anti-cancer treatment, they will kill all these rapidly dividing cells. So that's why they are bleeding, because no platelet can occur. The patient can be neutropenic. Yeah, the normal white blood cell is being destroyed, so they may have infection. Hyperleukocytosis is a presentation, one of the presentation. Yeah, the white blood cell is more than 100,000. Hemolysis syndrome is a complication of treatment. There's no need for you to know that much. Okay, next.
Okay. This is my references.
Okay, so late effect is late effect of treatment. Some patients with CNS leukemia may require radiotherapy to the brain. Okay, so that can cause a lot of late side effects, endocrine side effects, because it affects the pituitary even after the patient has been cured. So that is really late side effect. Patient with testicular cancer, for example, testicular leukemia, you have to irradiate the testes or cut off the testes. So the patient may not develop vascularization. The patient may be infertile. These are late effects. Patient given the treatment, for example, one of the treatment can cause damage to the heart, can have cardiomyopathy. Okay, that is what is meant by late effect. So Idham, your concept is wrong about late effects of treatment, more of late effects treatment. Okay, any questions about leukemia? 1 hour already. I'm losing my voice because I'm talking much more than Idham. Questions? No. Okay, let's go to the next one.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Sorry.
Okay,
how many slides do you have? Zulfarhan, how many slides?
Okay, my name is Muhammad Zulfarhan bin Zakaria. Today I will present about lymphoma, and this is my content of presentation. Start with definition, epidemiology, etiology, classification, pathogenesis, clinical manifestation, investigation, staging, treatment, prognosis, and complication.
So how many slides do you have?
And first of all, what is lymphoma?
How many slides do you have, Idham? And
What?
how many slides do you have, Farhan?
About 18.
18, okay. Yes.
Yeah, 18. Okay, what is lymphoma? Lymphoma is a malignancy of lymphoid tissue, and it usually affect the lymph node, and it can also affect other lymphoid tissues such as spleen and thymus, and it is a proliferation and replacement of normal lymphoid tissue with the malignant lymphoid tissue, lymphoid cell. And it has two types, which are Hodgkin lymphoma and non-Hodgkin lymphoma.
Okay, so lymphoid tissue is contained in the lymph node. Sometimes it is outside the lymph node. So these lymphomas can be nodal disease, that means in the lymph nodes, or extranodal disease outside the lymph nodes. Yeah?
Extranodal.
Yeah, okay.
Yes. Okay, for the epidemiology, lymphoma is the most common cancer in children, and in Hodgkin lymphoma, the incidence of Hodgkin lymphoma is peak in the adolescent in about 15 to 35 years, and it also can occur after 15 years. And it's rarely seen in children younger than 5-year-old, and in children, boys is what you call, the incidence of lymphoma is mostly occur in boy than girl. In the adolescent, the incidence between male and female is equal, and in non-Hodgkin lymphoma,
Zulfan,
the
please,
incident is
show your
is-
face, yeah. Okay.
Asyik
Okay, right. Tadi tak nampak muka tadi. Yeah. Okay.
mungkin internet lambat sikit.
Oh.
In non-Hodgkin lymphoma, it is increased with age, and male is predominant will can get the cancer.
So non-Hodgkin lymphoma can occur in younger children than Hodgkin, right? 5 years
Yeah.
old, and all that can occur. So,
The etiology lymphoma, the etiology of lymphoma is unknown, where there is no unknown, but is associated with the infection, immune suppression, and genetic. And in infection, the most what we call the lymphoma common associated with the Epstein-Barr virus (EBV), and other infections like human T-cell leukemia type 1, human herpes virus, Helicobacter pylori infection, hepatitis B and C, and it also can be associated with the immunosuppression, like inherited or acquired immune deficiency, mainly AIDS, or patient that undergo solid organ or stem cell transplant. And other associations like autoimmune disease like systemic lupus erythematosus, Sjogren syndrome, and autoimmune thyroid disease.
so the most common one infection is well-known EBV. Okay, you must know that.
Absolutely.
EBV. Immunosuppression is much more common in patients with AIDS. So this is more for adults, right? Because AIDS in pediatric is not very common. And transplantation, this is because to prevent rejection of the transplanted organ, you give immunosuppressive therapy. So that can cause lymphoma as well. All these autoimmune disease is not that common, yeah, because lymphoma. Yeah, all right.
Okay, next we go to classification. As we know, the lymphoma can be divided into Hodgkin lymphoma and non-Hodgkin lymphoma. In Hodgkin lymphoma, the classification can be divided into classical Hodgkin lymphoma.
Tak payah tahu lah ni kan. Tak payah tahu. But histological sometimes. Nak bagi cakap juga.
Histological between Hodgkin. Hodgkin lymphoma and Hodgkin lymphoma, usually the difference is in histological what we call
I cannot see your slides.
morpholation, where his Hodgkin lymphoma maybe my upload is low.
Okay, never mind. Boleh
Hodgkin
cakap.
lymphoma usually Hodgkin lymphoma usually is can presented with the red stem cell (RSL), where it is a pathognomonic feature of Hodgkin lymphoma. It is a large cell with multiple or multi-lobulated nuclei. And then this table show non-Hodgkin lymphoma.
The other student can see your slides now. I cannot see because all blank. I can hear your voice,
Yeah,
but I cannot see. What about the others? Can you ask the others whether they can see it?
See his side.
Can, doctor?
Can. Ada?
Ada.
Ada.
Okay, then never mind, carry on. Saya tak nampak apa-apa dah. Blank. Okay.
Okay.
All right, now I'm getting it again. Yes.
You see pathogenesis.
Yeah, yes.
In Hodgkin lymphoma, the pathogenesis is there is a translocation occur between chromosome 8 or if specifically in CMYC oncogene and the immunoglobulin gene locus in on chromosome 2, 14 or 22. And when when this oncogenes come to reside next to immunoglobulin gene, the gene turns on the immunoglobulin gene and it becomes overexpression and lead to malignant B-cell lymphoma. Okay. And next is clinical manifestation. Lymphoma.
Okay, so the one that I missed just now, you talk about classification of Hodgkin, histological
Hodgkin
classification, the classical one. There are four main types. I think maybe it's not necessary for you to remember, but if you want to be distinction student, you want to be oncologist, yeah, you need to know the four types. The commonest is nodular sclerosis, and then the most with poor prognosis is the lymphocyte depleted. Yeah. Best prognosis is lymphocyte predominant. So the more lymphocytes, because lymphocyte can kill the cancer cell. So lymphocyte predominant, good prognosis, lymphocyte depleted. There is not enough lymphocyte to kill the lymphoma cell, then worse prognosis. Okay, and then you talk about you're talking about Hodgkin first. Okay, yes, carry on that. Yeah.
Yeah.
Right. Yes.
In Hodgkin lymphoma, there's a process is four subtype, which is nodular sclerosis, mixed sociality, and lymphoid.
You mentioned that already, kan? You've gone through that already, that. Yeah. And Richthenberg, you must remember Richthenberg. Yeah, that's classical. That's pathognomonic. If there you see Richthenberg in the pathologies, I'm sure you have seen in pathology, then it is prognostic of Hodgkin lymphoma. Yeah. The cell was first described by the medical student in Germany.
And non-Hodgkin lymphoma, there is a pre-subtype, which is a small non-cleaved, which is Burkitt lymphoma, which is immunophenotype is it affect the mature B cell, and the primary site of this Burkitt lymphoma is usually in head and neck, or sporadically in abdomen. And the common translocation of the chromosome between chromosome 8 and 14, 2 and 8, and 8 and 22.
There's no need for you to mention detail that, but the diagnosis of Burkitt lymphoma, there is translocation involving that chromosome 8, 814, 28, 822. Chromosome 8 is always involved in the translocation. This is in the cancer cells, the lymphoma cancer cells. Yeah, so you can divide into lymphoblastic, large cell, and Burkitt. Easy for you to remember. Burkitt, yeah, BLL, Burkitt, and then lymphoblastic and large cell. Burkitt lymphoma is the commonest type of cancer in the African children. Yeah, not leukemia. Commonest type of cancer in other children outside Africa is leukemia. Yeah, but in African children, it is Burkitt's lymphoma. Lymphoma, non-Hodgkin lymphoma, almost the same as leukemia. You divide into B cell and T cell, yeah, just like you see in leukemia just now. Okay.
And other subtypes like lymphoblastic that affect the T cell, and the usual primary site is at the neck or mediastinum, and lastly a large cell where it affects T cell and B cell, and usually primary sites is lymph node, skin, soft tissue, and bone. And next is pathogenesis, where what I say just now is there is a transcorrelation occur between chromosome 8 and the immunoglobulin gene locus on chromosome 2, 14, or 22. And the occur gene comes to reside next to the immunoglobulin gene, and it become active or turn on, and then it become overexpressed and lead to malignant B cell lymphoma. Okay, next is a clinical manifestation. Lymphoma usually presented with the lymphadenopathy, where it is a
Yes.
Will presented with lymphadenopathy, where it described as a painless, non-tender, firm, and rubbery. For each type of lymphoma, such as Hodgkin lymphoma, is usually effect on the cervical supraclavicular axillary, and non-Hodgkin lymphoma is generalized lymphadenopathy. Also, because also it can also has symptoms related to lymph node enlargement in the organ, like if there is a lymphadenopathy in the mediastinum, it can cause cough, shortness of breath, or in the abdomen. If the abdomen is involved, it can lead to ascites or intestinal obstruction. For lymphoma, there is a symptom, what we call a B symptom, which is described as unexplained fever, which is high, more than 38 degrees Celsius, weight loss about 10% of total body weight over 6 months, and drenching night sweat. And also there is sign and symptom of anemia, infection, and bleeding. And if the lymphoma in the late stage, it may be hepatosplenomegaly, but it is a rare condition for lymphoma.
Okay, so non-Hodgkin lymphoma especially, okay, can invade the bone marrow. So it can cause anemia, can cause thrombocytopenia, yeah, it can cause infection. Hodgkin lymphoma rarely invade the bone marrow, but non-Hodgkin, yes. So you must do bone marrow routinely in all patients with non-Hodgkin lymphoma. And medicinal involvement is important. Some of the patients with lymphoma can come with stridor, noisy breathing. So you must do chest X-ray and you see that there is mediastinal mass. Then it can be a medical emergency and oncology emergency because it can cause pressure on the airway very fast. Patient come with stridor one day and difficulty in breathing, and within 1 or 2 days, if nothing is done, the patient may collapse because the airway is shut. Because the fastest growing tumor ever is Burkitt's lymphoma. So if there's Burkitt's lymphoma in the mediastinum, it can grow very fast. It can double the size within 48. The cell can double the number within 48 hours, from 100 cells to 200 cells, from 200 to 400, double the numbers within 48 hours. So it is a medical emergency. Abdominal involvement, they can present with intussusception, especially non-Hodgkin lymphoma. Yeah? So any patient more than 2 years old present with intussusception, you have to suspect lymphoma. Because more than 2 years old, it is not common to have intussusception unless there is some pathology in the ileocecal junction. These symptoms very important. I'm sure Farhan will explain. These are poor prognostic factors, isn't it, Farhan? You're going to talk about that?
Yes.
Yeah. Okay.
And this is a diagram shows warning signs of lymphoma, like unexplained fever, and the other. Okay, next is investigation. For the investigation, we must know what we want to find from the patient, like the processes of the disease itself, what we want, the investigation that can can cover the diagnosis of the disease, and like I said, the processes of the disease. Maybe it can be bad or good. For the first of all, from blood investigation, full blood count can for the lymphoma patient, it can come up with normochromic normocytic anemia, and in what we call in Hodgkin lymphoma can come up with pancytopenia, which is there is a decreasing number of the white blood cell itself and the platelet. Also, in serum lactate dehydrogenase LDH, in lymphoma, it can increase where it shows a tumor burden and prognosis for the cancer. ESR it is, and it used to monitor disease progression. To confirm the diagnosis of the lymphoma, we must do a lymph node biopsy where we do the histological examination where to find what kind of the histological morphology of the lymph node for diagnosis and classification of the lymphoma. And if there is a bone, what we call there is a bone marrow affected, can do a bone marrow aspirate for the staging and imaging. Like if there is any involvement, like patient come to us with the stridor or shortness of breath, we can do chest X-ray to see is there any mass in the mediastinum, and other imaging like CT scan and MRI to look for the extent of the disease and for the staging.
Okay, like I said earlier, I don't like to use the word scan. We use the word can. You cannot say patient come with stridor, we can do chest X-ray. No, patient come with stridor, you should do chest X-ray. Can tu mana boleh tu lah, boleh. Nak buat lah, tak nak tak apalah, can lah. Yeah. If your nurse asks you, want to do chest X-ray, doctor? Then say, oh, can lah. That's not the answer. Must do chest X-ray. So you must be more forceful in your presentation. You must say what you're trying to say. Okay. And like you say, if bone marrow is affected, you do bone marrow aspirate. How do you know bone marrow is affected if you don't do bone marrow aspirate? So you cannot say if bone marrow is affected, you do bone marrow aspirate. No, bone marrow is done routinely. Huh? Or if you suspect bone marrow is affected, then you do bone marrow aspirate. Yeah? You cannot say bone marrow affected, you do bone marrow aspirate. No, the other way around. You confirm that bone marrow is affected by doing bone marrow aspirate, and you do this routinely in all patients with non-Hodgkin lymphoma. In Hodgkin lymphoma, it's not necessary because it's very rare, unless it is high stage. Stage 3 Hodgkin lymphoma, you want to do it. Stage 1, if it's just stage 1, there's no need for you to do bone marrow because it's not going to go to the bone marrow. Yeah? And you know it's stage 1, only one lymph node is involved. If there are 2 lymph node areas, then stage 2. You still do not have to do. But if one on the opposite side of the diaphragm, that's stage 3, then even though full blood count is normal, you say, okay, we'll do a bone marrow aspirate. Okay, in real life, you don't monitor the disease by doing ESR. Okay, that's not important, right? And LDH is not a prognostic factor, so you don't alter the treatment based on LDH. Yeah. So it is raised, it tells you tumor burden. but it is not a prognostic factor. All right, okay. And the other imaging studies that's important is PET scan. So PET scan is useful especially for Hodgkin because it is very sensitive to monitor the site of the disease and to monitor the response of treatment. Yeah, using PET scan, right?
Next is a stage of lymphoma. For Hodgkin lymphoma and non-Hodgkin lymphoma, it has its own its own system. Like non-Hodgkin lymphoma is a Murphy staging system, and Hodgkin lymphoma is using a N-Arbor staging system. And for non-Hodgkin lymphoma, for stage one.
So basically it's the same, isn't it? About the same.
It's
one area lymph node. Use your pointer, Farhan. One area of lymph node, stage 1. 2 areas on the same side of diaphragm, stage 2.
Same side.
2 areas opposite side of diaphragm, stage 3. And then, if there are other areas affected, yeah, for example, the liver and the bone marrow, stage 4. But like I said, lymphoma, non-Hodgkin lymphoma, and leukemia are the same, almost the same disease. They overlap. So if you do bone marrow, okay, patient come with cervical nodes, and then you do biopsy, it is non-Hodgkin lymphoma. And then, like I said, you want to do routinely bone marrow, and you do bone marrow. And then you find that the number of blast cell, lymphoblast in the bone marrow is 30%. What's your diagnosis, Farhan?
What is it?
What, Dr. Guan? No. Yeah.
Tak work.
Kelantan ke?
Yeah.
Ya, sebab tu lah. Patient come with lymph nodes in the neck. You do biopsy. And you found that it is non-Hodgkin lymphoma, lymphoblastic. And then blood count shows mild anemia. And then you do routine bone marrow, and you found that the blast is 30%. What's your diagnosis?
Leukemia.
Yeah, so the diagnosis is leukemia. It's not non-Hodgkin lymphoma stage 4. But if the bone marrow shows that there's 10% blast or 15% blast, then you can say this is non-Hodgkin lymphoma stage 4. Okay, you see the difference? It is the same disease, depend on the number of blasts. Is the number of blasts more than 25%, it is ALL, less than 25%, yeah, 10% or 7%, then it is non-Hodgkin lymphoma stage 4, because bone marrow is involved. And you have made the diagnosis based on the lymph node biopsy. Understand?
Yeah.
Okay,
Understand.
next.
And for the treatment of the lymphoma.
So you go to N-Arbor for Hodgkin.
What?
Hodgkin disease, yeah, the next one, the one before this.
The Hodgkin lymphoma.
Hodgkin, you give
the
N-Arbor.
N-Arbor staging system.
So basically, it's all the same, right? One
yes.
cell and both on the same side, stage 2 on opposite side, yeah, and then stage 4, okay. And like I said, if this just 2 only from the scan and all that, there's no need for you to do bone marrow. But if you stage both sides of the diaphragm, then it is stage 3. The other thing about Hodgkin is that the lymph node spread is contagious. It doesn't go from here, from the cervical, doesn't go to the iliac, doesn't go from the cervical, goes to the inguinal. It goes down from the cervical, it goes to the chest, it goes to the axilla, then it goes downward. It doesn't skip, doesn't jump. Okay, whereas in Hodgkin lymphoma is different. You may have cervical involvement, and then you may have parailiac involvement without the thymic lymph node involved, without the mediastinal lymph node involved. Understand that? Go step by step. Dia pergi yang dekat dulu in Hodgkin. But it's not Hodgkin, it can go straight away to the distant lymph nodes. And the other thing about Hodgkin is the B symptoms is very important. Stage 3B is worse prognosis than stage 3A for Hodgkin, but not for non-Hodgkin. Right? Okay. Yes, next.
Okay, for principle of treatment, there is a determination of the treatment where it depends on the disease stage.
Okay, I think there's no need for you to go into the yeah. Basically, the principle of treatment of cancer is combination treatment. Okay, surgery, chemotherapy, and radiotherapy. So for Hodgkin, you use surgery. Yeah, the lymph nodes affected, you resect, and then you give radiotherapy only if after chemotherapy the disease is still there. Yeah, so again, combination chemotherapy. You give combination chemotherapy. After 2 courses, you do PET scan, and the scan shows that there is still residual lymph nodes there. After chemotherapy, then you give radiotherapy. Surgery is usually not needed. Yeah, non-Hodgkin lymphoma, surgery is not needed unless it is just localized, you want to do to resect it. But otherwise, it is not needed because they are very sensitive to chemotherapy. So you give chemotherapy, combined chemotherapy, radiotherapy is not needed. Yeah. And so basically, it is chemotherapy only for non-Hodgkin lymphoma, just like leukemia. Chemotherapy only, there's no surgery needed. Right? Radiotherapy only if the CNS is involved, but CNS involved, it is leukemia already. Testis is involved, you can give radiotherapy to the testis. But again, there's more of leukemia rather than non-Hodgkin lymphoma. Okay, so no need to know for you to know the detail. Any question on treatment? No? Okay, next slide.
Okay, the factor that influence the outcome, or if outcome is the higher the stage of the disease, when the higher the stage and the bad for the disease, the presence of the B symptoms depends on the type of the leukemia itself, and the presence of bulky disease, the involvement of extranodal extension, the leukocytosis and anemia.
Okay, the important one, this is more for Hodgkin, right? So B symptom, and then extranodal extension, for example, it goes to the spleen and all that involved, then it is poor prognosis. Leukocytosis, anemia, not important. Of course, the stage is important. So stage, B symptoms, and then extranodal extension for Hodgkin. For non-Hodgkin, again, the stage is important as well. Yeah? But overall, just like leukemia, the chances of cure is 80%. For non-Hodgkin also, the chance of cure is very good, even though it has gone to the bone marrow. But but still the stage is important. Yes. Right. And Hodgkin lymphoma is one of the best cancer to have. The chances of cure is very high. Yeah, more than 90% overall. So that's all you need to remember. Hodgkin lymphoma has best prognosis, more than 90%. Non-Hodgkin lymphoma, about 80% chance of cure overall. Yeah. And of course, it depends on stage, localized disease, better chance. Advanced disease, lower chance. Okay, next.
And lastly, the complication. For the treatment-related complication, it involves immunosuppression, where infection, cytopenia, and patient may having nausea and vomiting, and irreversible alopecia, which is what we call reversible hair loss. And as we know, the enlargement of the lymph node can what we call can lead to obstruction, such as like superior. If it evolve in medicine, it can lead to superior vena cava superior vena cava obstruction, acute airway obstruction, or in the abdomen, it leads to intestinal obstruction, and others like tumor lysis syndrome and secondary malignant neoplasm.
So you can divide, to make it more clear, you can divide complication into acute complication and late complication, okay? So acute complication, the 1 to 5, these are acute complication. Acute complication, you can divide again into acute complication of disease and acute complication of treatment. Number 1 is treatment-related complication, right? Immunosuppression, infection, cytopenias because of bone marrow suppression. Tumor lysis syndrome, also an acute complication of treatment. This is because when you start treatment, the cancer cells are very sensitive to treatment. All of them rupture and they release the uric acid from inside the cells. And this can cause acute kidney injury. So tumor lysis syndrome causing acute kidney injury because of the release of uric acid from the cancer cells when they receive chemotherapy. 2, 3, and 5, these are complications of the disease itself. Acute complication, presentation in fact. Yeah? When there is lymph nodes in the mediastinum, it can suppress on the superior vena cava. And this is called SVC syndrome, superior vena cava syndrome. They can compress on the airway, causing obstruction. This is also called supramediastinal syndrome, superior mediastinal. Yes, superior mediastinal syndrome. Number 6 is late complication. Patient who has been cured of cancer, okay, any cancer, they can have a second cancer. Maybe because the cells of the body are not good in the first place, that's why they get the first cancer. So they may be able to get second cancer. And sometimes the treatment itself can cause second cancer. The radiotherapy, if given, can cause second cancer. So this is called SMN, second malignant neoplasm, late effect of treatment of cancer. And of course, there are other late effects of treatment. If given radiotherapy, for example, there is asymmetrical of the growth. We have seen patients with cervical Hodgkin and given radiotherapy to the neck, and then one side of the neck is smaller than the other side of the neck. One side of the cheek is smaller because the radiation hits the cheekbone as well. So one side of the cheek, so the face becomes asymmetrical. And then if you irradiate the neck, the thyroid gland may be affected. The patient may get hypothyroidism. And one of the complications of chemotherapy for Hodgkin disease is you can get sterility in boys, because it can decrease the sperm count. So these are all late effects, which are there even after the patient has been cured of the disease. Okay, understand? Idam, now you understand what late effects are? All right.
Yes.
Any questions?
Yes.
No question. So that we jump. Okay, we have 2 more speakers. Right, next.
And this is my faces. And this is my faces. I think that's all for me. Thank you.
I'm sorry, Prof. We actually
Yes.
have a total of 5 presenters today.
5 presenters.
Yes.
Tak semayang, tak salah asal lah kita sampai maghrib. Buka puasa terus. Okay, what's the 5th speaker going to talk on? Idham. Kata 4 speaker saja. Okay.
Sorry, Prof.
Okay, come on. Next. Who's the third speaker?
Macam mana nak cancel? Macam mana nak cancel?
Where is the third speaker? Come on. Where is the third speaker? Not here.
Assalamualaikum, I am the third speaker. I'm sorry, my laptop just died. Let me share my slide.
What are you talking on, Neville?
I am the third speaker.
Yes, what are you going to talk on?
I am going to talk about neuroblastoma.
And how many slides you have from neuroblastoma?
34 slides.
Huh?
34 slides.
34 slides.
Yeah, but
MashaAllah.
there's lots of pictures and my font is kind of big. So
Okay, right.
okay.
Oh, because your name is Nurul Putri, so you're going to talk on neuroblastoma.
Yeah. Can everyone see the slide?
Yes, we can.
Yes.
All right. Okay. All right. Okay. So neuroblastoma. So I am going to present about neuroblastoma.
Okay.
So these are the contents of my presentation. Okay, let's start with the introduction, which I will define and give out the incidence of neuroblastoma. The definition of neuroblastoma is actually embryonal carcinoma of peripheral sympathetic nervous system, in which these tumor cells derive from neurocrest cells. So,
where do you get the definition?
from textbook.
What book?
Nelson textbook. Yeah, Nelson textbook. 20
So
years.
what does the word CA there stand for?
Carcinoma.
It's not a carcinoma.
Cancer.
Yes, it's a cancer. Carcinoma is very rare in children. That's the difference between adult cancers and pediatric cancers. Almost all adult cancers are carcinomas. So that's why it is easy. You have nasopharyngeal carcinoma, cervical carcinoma, hepatocellular carcinoma, renal cell carcinoma. These are all adults. Carcinoma are cancer of the epithelial cells. So this neuroblastoma is cancer of the embryonal cells. It's not of epithelial cells. So don't say it is embryonal carcinoma, it's embryonal cancer.
Yeah, that is my fault.
Of course, it's your fault.
Yes, it is. Moving on. So the tumor can be found in adrenal glands and paraspinal nerve tissues from the neck down to the pelvis.
So based on that, okay.
Yes.
Based on that, the neuroblastoma cells can be intra-abdominal. That means from the adrenal or from the parasympathetic of the lumbar region. It can be mediastinal tumor, okay? Because from the parasympathetic of the one that occurs in the thoracic one. So it can be a mediastinal tumor or it can present as abdominal tumor.
Yes.
Right.
Moving on, the incidence of this neuroblastoma, it is actually the most common extracranial solid tumor of childhood and also the most common malignancy in infancy. With a median age of around 22 months, 90% of the cases is by 5-year-old child, and it accounts for around 1 out of 7,000 live births. It is usually sporadic, but only 1 to 2% presented with a family history of neuroblastoma. The mortality from this type of cancer accounts for around more than 15%. It is usually high in boys and whites, but in Malaysia, since we are Southeast Asian, it is quite rare here in Malaysia.
No, it is about the same as in other countries. The incidence of neuroblastoma is about 7 to 8% of all childhood cancers, but the mortality count 15%. So that means it is very bad prognosis. Neuroblastoma has bad prognosis. So it is the second commonest, third commonest cancer in children, or what? Nurul,
If I'm not mistaken, second.
second, it's the third. The commonest is leukemia.
Yeah.
The second is brain tumor.
Oh,
Yeah. So it is second solid tumor, according to you. Where's Farhan? Mana Farhan?
Yes, Doctor.
Farhan, you said lymphoma is the second commonest to the brain tumor.
Huh? What?
What do you say about
Lymphoma.
Lymphoma? What number?
Lymphoma is the third most common cancer.
So the first is?
The first is leukemia.
The second?
The second,
A brain tumor.
brain tumor.
So lymphoma is the third.
The third.
But according to Nurul, this is the third. Commonest is leukemia, second is brain, and outside the brain, the commonest is neuroblastoma. So that means neuroblastoma is the third. Yang mana betul?
Okay. The lymphoma is third.
Lymphoma is more common than neuroblastoma if you combine together. If you combine non-Hodgkin lymphoma and Hodgkin lymphoma together, it is the third commonest. It is the second commonest solid tumor after brain tumor. So this one is number 4. Neuroblastoma is number 4. Right? After lymphoma. Yeah, okay.
Okay, moving on. Is the etiology. So mainly it is unknown. However, there are some researches that states that there are some prenatal or perinatal events that may predispose to neuroblastoma, such as anemia of pregnancy and neonatal distress. This is because of the decrease in blood oxygen carrying capacity during gestation and perinatal period may interfere with the maturation.
I don't think these are well-known etiological factors. Yeah. So don't worry about that. This is maybe very, very small. Yeah. Maybe one case report here and there. So it is not well known, not well accepted.
Yeah.
Etiological factors. Yeah.
So in case of hereditary, which is rare.
Yeah, no need for you to remember that. Okay.
Yeah, this is just to mention it. Okay, so moving on, which is the difference between neuroblastoma in pediatrics and in adults. In adults
rarely get neuroblastoma.
Yeah, rarely.
So don't worry about adult neuroblastoma. You're not dealing with adult and they're very rare. Forget about it.
So, okay. Then moving on to the example based on the locations involved. So this is a diagram based on the location involved. Most common location is adrenal gland, which accounts for around 35%, as well as the paraspinal ganglia in the low thoracic abdominal, which accounts for 30%. And we could also find the tumor in cervical sympathetic ganglia or mediastinum. And in case of metastasis, it mainly metastasis to the bone marrow, liver, lymph nodes, and skin. So this is the example of an MRI for chest neuroblastoma. So this tree ABC diagram is for the same patient, while D and E is for another patient. For the first patient is actually a newborn with L2 stage left posterior mediastinal neuroblastoma. So you could see that it is actually marked by this star marking here, the tumor, and it is uniquely well delineated with focal contact with the thoracic aorta and the intraspinal extension, here arrow. And this C here is actually a follow-up MRI after neoadjuvant chemotherapy. You can see the residual tumor over the costal vertebral junction. So, and this one, you could compare the tumor with this patient and the first patient here. This one is from a 9-year-old girl with end-stage mediastinal neuroblastoma. The tumor here is ill-defined and it actually diffusely infiltrates the posterior mediastinum, the pleura, and the chest wall. So the tumor also crosses the midline and encasses the thoracic aorta here, the arrowhead.
Okay, so what you can learn from here is that neuroblastoma can occur in newborn. Yeah, can be congenital neuroblastoma. Some of the congenital neuroblastoma can disappear spontaneously without any treatment. Right? And then the staging of neuroblastoma is different. It's now stage 1, 2, 3, 4. Previously, they have stage 1, 2, 3, 4, stage 4S. Now it is L1, L2, and M. M is metastatic. L is local disease, but they spread outside the origin. Yeah? L1, it is still localized. Okay. Yeah, can we continue?
Okay, moving on. This is the example of abdominal neuroblastoma. This one is a CT scan of this 8-month-old girl with right adrenal neuroblastoma. It is actually right on the right adrenal, which is in between of the right kidney as well as the inferior vena cava here. You see that it also crosses midline and have a focal contact with the thoracic with the aorta.
So crossing the midline is one difference between Wilms tumor and neuroblastoma. Neuroblastoma can cross the midline. It can cross to the other side of the spine. Whereas Wilms tumor, it is from the kidney, it does not cross the midline. Does not cross to the other side. One differentiating factor, if you have a tumor in the abdomen which is ballotable. So ballotable means that the kidney or adrenal crosses the midline, then it is adrenal tumor, neuroblastoma. If it does not cross the midline, it can be either one. It can be neuroblastoma still, it can be Wilms tumor, but if it crosses, it cannot be Wilms tumor anymore. That's not likely.
Moving on is an example of metastasis. You can see that in diagram A is the CT shows the CT scan shows large retroperitoneal neuroblastoma, which encasses the abdominal aorta and replaces the displaces the inferior vena cava. This is the tumor, and this one is from 123I meta iodobenzene guanidine scan. So you can see that there's dense localization of the primary retroperitoneal mass, and this darkened area shows evidence of widespread bone metastasis. Okay. Moving on is the clinical presentation. So the clinical presentation of neuroblastoma may mimic other disorders, hence it might cause delayed diagnosis. The most common presentation is abdominal pain or mass, and when it is palpated at the flank, we could feel it hard, smooth, and non-tender mass. The signs and symptoms reflect the tumor site and the extent of the disease, such as there's localized symptoms of the tumor because of the mass itself, for example, spinal cord compression or bowel obstruction.
Okay, so one important thing about the mass is that it's ballotable, right? You know what is meant ballotable? Okay, when you go to the clinic next time, okay, they will teach you how to ballot for the kidneys. These are for retropharyngeal mass, retroperitoneal mass. Kidneys, adrenal are retroperitoneal, so it is ballotable. Spleen and liver, these are not retroperitoneal, they are intraperitoneal. Yeah? So they are not ballotable. So the mass is ballotable, hard, smooth, and non-tender.
Moving on, since this tumor can be at any site of sympathetic nervous system, it can also present with neurologic signs and symptoms. For example, if the tumor originates from superior cervical ganglia, it can exhibit Horner syndrome, which can be seen by neck or apical methods. If it is paraspinal neuroblastoma, the tumor may invade neuroforamina and causing spinal root and nerve root compression. And in such cases, in certain cases, they can also lead to a syndrome called opsomyoclonus, which is described. The condition is described as dancing eyes and feet. But to explain to you the features, is actually myoclonic jerking and random conjugate eye movements. Okay. Moving on, since the tumor can also affect adrenal glands, so some tumors may produce catecholamines, therefore can exhibiting effect of catecholamines such as increased sweating and hypertension, release of vasoactive intestinal peptide, which leads to profound secretory diarrhea. In such cases with extensive tumor, it can lead to tumor lysis syndrome as well as the IC, disseminated intravascular coagulation. Okay. In cases of metastasis in children more than 1 year old, the most common site is actually regional or distant lymph nodes, long bones and skull, bone marrow, liver, and skin. And these children may present with fever, irritability, failure to thrive, bone pain, cytopenias, bluish subcutaneous nodules, orbital proptosis, and periorbital ecchymosis. This picture shows the periorbital ecchymosis. You can see the bluish, purplish color below their eyes. Moving on to the investigations. So the lab investigation is full blood count. We could see low RBC count because of anemia. For plain radiography, we could also do plain radiography, CT or MRI that may shows multiple masses, calcification, and hemorrhage. We can also do prenatal diagnosis, and it can be sometimes useful to do maternal ultrasound scans. The tumor markers that involve is catecholamine metabolites such as homovalinic acid, HMVA, and vanillin mandelic acid, VMA, which can be elevated in urine, 95% in the cases. We should also do genetic studies to detect for the oncogene of MYCN. The importance of oncogene MYCN here, it is actually a gene that is involved in cell division, and the presence of amplification of MYCN can determine the prognosis. We can also do bone marrow aspiration as well as biopsy. However, neuroblastoma can be diagnosed.
Can you go back? Okay. Genetic studies should be done in all neuroblastoma cells. Okay. You do biopsy and then you send the tumor cells for oncogene MYCN. Just like leukemia, you do molecular studies for neuroblastoma, because this will tell you the prognosis whether you want to give very aggressive treatment or not. Bone marrow aspiration can be done, should be done in all neuroblastoma. Yeah, because you want to know whether it has gone to the bone marrow or not. So common site of spread is to the bone marrow. Tumor markers should be done as well, yeah, because it is useful, and it is useful to monitor the progress as well. Tumor marker may be positive, and then when you give treatment, and then if the disease is in remission, the tumor marker will be negative. And when they relapse, the tumor marker will be positive. You don't do perinatal diagnosis for neuroblastoma, but it can be detected by maternal ultrasound, routine ultrasound. You don't do ultrasound to diagnose neuroblastoma. Just because there may be a sibling with neuroblastoma, you don't say, okay, let's do monitor the mother, see whether there is any neuroblastoma or not. No, you don't do that. But it is just incidental finding. Yeah, you do ultrasound to check the fetus as usual and all that, the fetal growth, and then you may find that the fetus have very big liver. Yeah, or big mass in the abdomen. So can be picked up antenatally. And you don't say CT scan, radiograph, MRI can be done. It should be done. CT scan especially should be done. Then MRI is more sensitive, but usually CT scan is enough. And if a CT scan is positive, then the next scanning you want to do is MIBG scan, which you showed that just now. Yeah, monoidal something scan. Which picture I show. CT scan, the plain X-ray is not very informative. Unless patient, you do not know the diagnosis, patient will come with cough and with compression of the chest and all that. Then you want to do chest X-ray, show medicinal mass. And then straight away, you can do CT scan of the chest and pelvis, abdomen, to see whether any other areas is involved. And then you do PET scan. Okay, next.
Okay. However, neuroblastoma can be diagnosed without biopsy if this small round blue tumor cell is observed in bone marrow samples as well as positive internal markers. So these are the example of neuroblastoma cells aspirated from bone marrow. The clumps of cell often contains more than 3 cells, and it is characteristic of neuroblastoma is actually rosette of cells surrounding an inner mass of biliary materials, as shown here.
So neuroblastoma is one of the rare pediatric cancers which you don't have to do a biopsy of the tumor itself, of the primary site, for you to start treatment. Okay, if tumor marker urine VMA is positive, and then if bone marrow is affected, you do bone marrow aspiration, you find small round blue cells. Yeah, then you can make diagnosis and start treatment. But sometimes the bone marrow is not involved. But if you do CT scan, like what was shown just now, and you showed that the adrenal mass, there is adrenal mass, and then tumor marker is positive. Again, you can make diagnosis even without doing the biopsy, because it may be difficult to do a biopsy of the adrenal. Or if patient has got paraspinal, okay, from the sympathetic nerve, from the CT scan, oh, this is paraspinal, and then you do VMA is positive. Again, you may start treatment without doing a biopsy, because all this, because the urine VMA, the tumor marker is very specific. Yeah, it is not pathognomonic, but it is specific, and plus radiological features. You can make the diagnosis, or plus the histology of the metastatic site, the bone marrow, you can make the diagnosis. Yeah, okay.
Moving on. So for investigation, in case of metastatic disease, we should do CT or MRI of the abdomen, bone scans to detect the cortical bone involvement, and at least 2 independent bone marrow aspirations and biopsies.
Okay, so nowadays you do MIBG scan, right? So there's no need to do bone scan. There's no need to do, CT, MRI, you want to do MIBG. CT or MRI, yes, for the abdomen, but otherwise, for the whole body, you do MIBG scan.
Moving on to the staging. So we actually use International Neuroblastoma Staging System, INSS. So this is the staging system, but
okay, this is not used anymore now, right? You use LM.
But this is what I mean the textbook. So
so this is until a few years ago. So now it's not used anymore. But what you need to know is there is stage 4S.
4S here, which is limited to infants less than 1 year of age, and it is described as localized primary tumor with dissemination limited to skin, liver, and bone marrow only.
So this is stage 4 tumor, but doesn't go to the bone. If it goes to the bone, cannot be stage 4S. Yeah. So it can go to the skin, liver, and bone, but not the bone marrow, but not to the bone. And then must be less than 1 year old. Why this stage 4S? Because this is a special. It can disappear spontaneously without any treatment, and the prognosis is very good. Yeah. See that prognosis, survival 80% chance of cure without any treatment. Yeah.
Moving on, the prognosis factors, principal management, and outcome. The reason why I combine these three together because it is very interrelated. So first is prognosis factor. To determine the prognosis factor, we need to classify the patient in which type of risk group. It's either low, intermediate, or high risk group. So for high risk group, if you can see here.
I think there's no need for you to know too much detail. The age is very important, all right? The risk factor. And then make N is very strong prognostic factor. If it is amplified, then it is poor prognosis. Even low stage, okay, if it is magnified, amplified, then it is high risk. Yeah, even stage 1, you see stage 1, if MIG is amplified, the risk group is high. So very strong prognostic factor. Ploidy, okay, but the hyperdiploid is not as strong as MIG-N. Yeah, so never mind. Histology, very difficult, because histology very difficult for two pathologists to agree what the histology type. So not very important. I think you need to remember MIG-N. This is the most important. Yeah, prognostic factor. MIG-N and the stage, of course. Yeah. So the lower the stage, without MIG-N, the prognosis is good. So low stage and MIG-N. Okay. I need to know the details. Yeah.
So where we have classified the patients, then we can come up with the principle of management, and these are the respective outcomes. So for low risk, we should give surgery because most of the case with low risk, the tumor is resectable and they usually have a high survival rate of more than 98%. For intermediate risk, we should give moderate intensity chemotherapy as well as surgery with a survival rate of 90 to 95%. For high risk, of course, the treatment is more aggressive. So we give dose-intensive chemotherapy, surgery, external beam radiotherapy to primary tumor, as well as the registered metastatic site, myeloablative chemotherapy with autologous hematopoietic stem cell rescue, and others. So the survival rate as compared to low and intermediate risk, as you can see, it is actually lower with around 40 to 50% of survival rate. And for high risk patient, we need to also consider of recurrence, and there are certain certain cases of recurrence in which the tumor during the recurrence are not responding to the chemotherapy. So in such cases, we need to come up with a new principle of treatment, with new kind of treatment. For tumor stage 4S, as Dr. Hel mentioned before, we just do supportive care and just observe, because most of the time it could just regress spontaneously, and it also has a survival rate of more than 90%.
So you can see the difference between high risk and the others. Yeah, almost half, 40% survival on it. And what you have to remember is that neuroblastoma, most of them present metastatic disease. So most of them are high risk. Most of them present with metastasis to the bone marrow and to the bone. So most of them are high risk. So even though prognosis is good for stage 4S, for low risk, intermediate risk, but because most of them present with high risk, the overall prognosis for neuroblastoma is only about 60% only. One of the worst cancer in children. All right, next.
Moving on to the complications. So of the complications, like I've mentioned before, the localized tumor may lead to spinal cord compression.
So, yeah, these are presentation, right? Yeah, maybe presentation with complication, yeah, all right. And this is not complication, this ophthalmologist is just a presentation as well, okay? So these are late side effects. Aggressive chemotherapy gives rise to second malignancies, growth problem, like I said just now, can damage the kidneys. Yeah, so these are late side effects of treatment, because the treatment has to be aggressive, so they have a lot of late side effects. Right, next.
That is all. These are the references.
So in summary, neuroblastoma is the fourth commonest tumor. Prognosis is very rare. Prognosis is very poor, and if they come with a poor prognosis, one with stage 4 and with MIG-N, then the curative treatment is bone marrow transplant. And usually you have to do surgery, you have to do radiotherapy as well. Yeah, for residual tumor, because sometimes you cannot resect all of them. So combination chemotherapy, combination treatment, multimodal treatment, combination chemotherapy, and prognosis poor. Okay, any questions? Two more. I'm losing my voice now. Okay, who's the next speaker?
Me, doctor.
Okay, me. Okay,
Aisha.
me, Aisha. Yes. What are you going to talk on?
Okay.
What are you going to talk on, me? Where is me? What's your topic?
Nephroblastoma.
How many slides?
Wilms tumor.
How many slides?
Around 24.
Okay.
Okay. Assalamualaikum warahmatullahi wabarakatuh. So I'll be talking about Wilms tumor, or also known as nephroblastoma. So these are my outline. Okay. So basically, Wilms tumor, or also known as nephroblastoma, is a renal malignant tumor, and it is the most common renal malignancy in children. Nephroblastoma is originate from the embryonal renal tissue. So the annual incidence of nephroblastoma, it is approximately 7 cases per million in children younger than 15 years, and it accounts for about 5% of all childhood pregnancy. 95% of the Wilms tumor cases, it involves children below than 15 years old. In terms of gender, male has lower incidence rate rather than female. For the ethnic groups, African Americans have higher incidence rate than Asian. This is due to epigenetic differences that contribute to the lower rate of disease in Asian children. So as for the etiology, it is unknown, but it is thought to be caused by mutation of genes responsible for the genitourinary development. For example, WT1, WT2 gene locus, P53, familial WT1 and T2 genes. And Wilms tumor, 10% of the cases, Wilms tumor can occur as a part of multiple malformation syndrome. For example, in WAGR syndrome, which is a syndrome of Wilms tumor, aniridia, which is the...
Okay, these are very rare syndromes and all that. I think there's no need for you to know in detail, yeah? Just suffice for you to know that there are certain syndrome which is associated with increased incidence of Wilms tumor, yeah? All these are all very rare, yeah.
All right. So basically, the pathogenesis is caused by abnormal renal development, which will result in abnormal proliferation of metanephric blastomer cell without normal tubular and glomerular differentiation. So it includes the mutation of these genes stated here. It is stated that the role of this gene mutation in the pathogenesis is remain unknown. So from the nephroblastoma or Wilms tumor, they are mostly solitary lesion. 5 to 7% have bilateral renal involvement. So the gross features may include cyst, hemorrhage, and necrosis. And it is the tumor typically surrounded by a pseudocapsule with infiltrative border. From the microscopic features, there are 3 types of cells that can be seen, which is the blastomer cells, it is undifferentiated cells. You can see here. Okay. Second type is the stromal cells, which is in nature spindle cells and heterologous skeletal muscle, cartilage, osteo, or fat. The third one is the epithelial cells, which form the glomeruli and tubules. For Wilm tumors, some tumor contain only one or two cell types. If only one cell type occur, it is very difficult to make diagnosis of Wilm's tumor. As for the clinical presentation, patient will commonly come with abdominal mass or swelling, which accounts for 80% of the case. And also they come with abdominal mass without any other symptoms. Okay, so other symptoms that they can come with is abdominal pain, hematuria, fever, hypertension, anemia, which is these are the symptoms that is less commonly patient will come with. As for the respiratory symptoms, if they have if the tumor is already metastasized to the lung, they will have respiratory symptoms. But usually, this rarely happen.
The metastasis to the lungs is not that rare, but it has to be the whole lung involved. If there are 4 or 5 nodules and all that, okay, there is still no respiratory distress, right? But if there are a lot of nodules in the lungs, then only you can get respiratory distress. So as a symptom, respiratory symptom is rare, but that does not mean that there is no respiratory involvement. Also present with incidental finding of abdominal mass. The parents changing the nappies, for example, or changing the pants, or bathing the child, and suddenly feel that there's a mass in the abdomen. Or the patient go to hospital for some other problem, for cough and runny nose, or pneumonia, and then a doctor from IIUN, we bring a good doctor, do a thorough examination, check the abdomen, and find incidental finding of a palatable mass. Okay, so they are asymptomatic usually. Yeah, and the common age group is, of course, it can occur in children up to 15 years old, but it is usually common in children less than 5 years old. Yeah, so the child would not complain, oh, there is a mass and all that. Yeah, so it's usually incidental finding from the parents or from the doctors. Okay.
So from the physical examination, the physical examination will reveal a firm, non-tender, smooth, and palpable abdominal mass here, and also stated by Prof before, it is rarely cross the midline. And also, if Wilm tumors is associated with congenital syndromes, assessment for the anomalies should be done. So this aniridia, which is the absence of iris, hemihypertrophy, which is you can see one side of the body part is larger than the other side, and also genitourinary anomalies. So for the investigation, we can do laboratory testing, which include complete blood count to check for anemia, renal function test, urinalysis, and liver function if liver metastasis is suspected. Coagulation study is done if the patient have history of bleeding or hypervascular tumors. And cytogenic, other than that, cytogenic studies can also be done. So next is the imaging studies. Imaging studies can be abdominal imaging or chest imaging. Abdominal imaging is done to differentiate Wilm's tumor from other abdominal masses, for example, like neuroblastoma. Okay. As for chest imaging, it is done to determine whether there are lung metastasis or not. Okay.
So you cannot lump all these investigations together. You see a patient, you suspect the patient present with abdominal mass. So the first thing you want to do is ultrasound to see where the mass arise from, whether it's from the kidney or from what. Yeah. And then after from ultrasound, then you want to do CT scan. You want to do CT scan of the abdomen as well as the chest to see whether there's any lung involvement or not. You want to stage the disease. All this CBC and all that, this is just a baseline when you start treatment because it does not go to the bone marrow usually. So there's no need to do CBC. Kidney function, even though they have a big tumor in the kidney and that, even if it's bilateral, usually the kidney function is not involved. That's why a patient with Wilms tumor, you can just remove the kidney, one kidney. Yeah, because the other kidney is a good kidney, is good enough. So kidney function is to monitor when you give treatment because some of the treatment can cause renal dysfunction. Urinalysis, okay, does not have the diagnosis, just tell you whether there's any RBCs or not, whether hematuria or not. And that occurs in less than 10% of patients. Liver function test, even if they have a liver metastasis, which is very rare, the liver function is not affected. Even patient with hepatoblastoma, liver function is not affected because the liver had to be really, a large percentage of the liver is damaged, then only liver function is affected. Yeah. Cytogenetic studies, you cannot say it cannot be done. It is you cannot say it can be done. It is recommended to be done because you want to see whether there's any mutation in WT gene or not, WT1 or WT2. Yeah. So definitive diagnosis is biopsy. You do biopsy before starting treatment, or you give treatment first, and then after treatment, neoadjuvant chemotherapy, you do surgery, you send the whole kidney for the histology. So either biopsy, which is not necessary if the child is less than 6 months old, yeah, you give neoadjuvant first. Because when you do a biopsy, you are puncturing the tumor. When you puncture the tumor, then if the tumor is stage 1, it can become stage 2 because you puncture the tumor already. And stage 2 has poorer prognosis. So that's why biopsy is not recommended. You can give chemotherapy first.
So the definitive diagnosis is through histopathologic confirmation. Okay. As for the staging, it is determined based on the anatomic extent of the tumor without consideration of the genetic, histology, and also biologic markers. Typically, higher stages have more extensive disease and worse prognosis. So generally, from the picture, if the tumor is in stage 1, the tumor can be found in the one kidney, and the size of the tumor will be small, and it can completely remove with surgery.
The size does not determine the stage. It is whether it infiltrate the capsule. Stage 1, it does not infiltrate the capsule, stage 1. Stage 2, infiltrate the capsule. It bursts through the capsule. So that's why you don't want to do biopsy, because you do biopsy, that means you're infiltrating the capsule from stage 1 and becomes stage 2. Stage 3 goes outside the kidney, local spread, yeah, either to the lymph nodes or to the tumor thrombus. Yeah? And stage 4 is to other organs. If it goes to the lymph nodes, it is stage 3. Yeah? It's not stage 4.
Actually, in Wilms tumor, there are 2 staging systems that can be used, which is the National Wilms Tumor Study and NWTS is based on the surgical evaluation prior to the administration of chemotherapy.
Okay, this is the American. They will insist on biopsy first. Yes. Okay, this is the British or international. Okay, no need to biopsy first. You do give chemotherapy first, then you do biopsy. Or you do surgery and give the whole kidney. Whereas the American, they will do needle biopsy or true cut biopsy first. But now even the Americans are changing now. They're giving neoadjuvant first before they do biopsy. Okay.
So Okay, so these are the details of the staging system. Basically, you have to know that NWTS, it is the
I
the
think
staging is
there's no need for you to
okay.
detail all this staging. Yeah, not important.
Okay. So this is the SIOP. As for the treatment and management,
The only thing that you need to remember is that there is, if it is bilateral, it is called stage 5. Can you go back?
yeah.
So bilateral is stage 5, yeah? Whether it is NWTS or whether it is the international staging system, stage 5. Stage 4 is distant. Stage 3 is local spread in the abdomen. Stage 1 is in the kidney alone. Yeah, right.
Okay. As for the treatment and management, Wilms tumor, the approach consideration involve surgery, chemotherapy, and with or without post-operative radiotherapy. So based on the staging system, they have different
okay, no need to know for you to know the detail. All of them will require surgery. Okay, yeah. And all of them will require chemotherapy. Surgery is nephrectomy, total nephrectomy, even though there are studies now doing just partial nephrectomy. But most protocol, even though the upper pole involved, you do nephrectomy and then chemotherapy. Usually it is neoadjuvant, you give before surgery and then you give after surgery. Radiation, if only the local stage 3. Stage 1, stage 2, no radiotherapy. But stage 3, you give radiotherapy to the primary site. Yeah, okay.
So for the management of lung metastasis, chemotherapy is done. If a complete response occurs, lung irradiation may not be needed. If
you don't do lung irradiation because lung tissue is very sensitive to radiation damage. So even if there is no complete response, lung radiation is not done usually. Yeah, what you do is you remove, you try and remove. This is called cherry picking. Cherry picking because the metastases are like cherries. Yeah? So you just remove one by one, remove one by one. Even if there are 10 metastases, you remove one by one, and then you continue with the chemotherapy, but no radiotherapy.
For the management of bilateral Wilms tumor.
Okay, there's no need for you to know this because bilateral Wilms tumor is only 5% of Wilms tumor. Okay. No need for that to know detail. You're not going to be an oncologist. Yes.
Okay, for the tumor, if there is tumor recurrence, high-dose chemotherapy with stem cell rescue is done, but the efficacy remains unknown. As for the follow-up is needed for the ongoing surveillance for tumor recurrence and also late treatment-related complication.
All cancer patients, you follow up for life.
Yeah.
Okay. After they have been cured, after 5 years, you follow up every year, once a year, to see whether there's any late side effects or not. Yeah. Okay.
So, as for the prognosis, Wilms tumor is a curable disease which have 5-year survival rates and more than 90% of cases cured. Okay. It also vary among individuals, depends on the tumor histology, stage, size of the tumor, and also patient's age. If there is tumor recurrence, there will be tumor recurrence will occur 50% in favorable histology, which is no anaplasia feature, and also occur 50% in patients with anaplastic features. If there is tumor recurrence, the prognosis will be poorer, around 50 to 80%. Okay. So for the
relapse cancer is always poorer than the first time, right?
Yes. So for the prognostic factors, the first one is the tumor histology, which
okay, no need for you to know detail. If this anaplastic, then poor prognosis. Okay.
Poor prognosis. Okay.
Right. That's fine. Okay, not important, right?
Okay.
Next.
As for the tumor stage,
Okay.
The
One more
higher
stage.
stage
Yes.
will have poorer outcome. So as
But
for the
stage 4 has poor prognosis than stage 5. So even though 5 is higher stage, but it is better prognosis than stage 4 because stage 5 is bilateral but does not go to the lungs. There's no distance metastasis.
Okay. For the molecular and genetic markers, loss of heterozygosity and also 1q gain associated with risk of relapse of the tumor and also mortality in some patients with favorable histology, which is no aphasia. As for the age, historically, children less than 2 years.
So this is historical. It's not important anymore. The age is not an important prognostic factor anymore.
Okay. So basically, age is not
not important prognostic factor. Full stop.
Okay.
Right.
So as for the complication, the one that I stated here is due to the treatment. So early complication is related to therapy, adverse effects of chemotherapy drugs, and also surgical complications such as bowel obstruction, hemorrhage, and wound infection. Okay. As for the late effects, it depends on the type and intensity of therapy. Basically, more intense chemotherapy and radiation therapy will have more likely to have complications. So these are the examples of late complication due to treatment. Renal impairment,
Okay, we have
cardiotoxicity.
mentioned all these, right?
Yeah.
Most of the cancer drug can cause cardiac damage. So we have to monitor properly, can cause liver damage, can cause infertility, can cause second malignancies. All have been mentioned, can cause growth impairment also. Okay, next.
Okay, so that is all from me.
Okay, okay, good references, all very current. Yeah.
Okay.
Okay, any questions?
Thank you.
2 more speakers.
One more.
Baik, one more. Dah pukul 5 dah. Okay, one more you have to finish in 15 minutes. Brain tumor, and it is the most complicated tumor of all. Who's the next speaker? Ramai betul nama Mi.
Shamimi.
Mi Shamimi. You have 3 Mi's. How many slides you have?
24.
24. Okay. Yes.
So you can see my side. Assalamualaikum, my name is Shamimi Saleh and I'm going to share about the brain tumor in pediatrics. So basically, brain tumor, like the name, is a mass or growth of abnormal cells located in the brain where it can be benign or malignant. Okay, so this is the content. Okay, first one about the incidence. As been told before, it is the second most common malignancies, and for overall annual, it is only 44.7 cases per 1 million children below than 20 years old, where the highest is in infants and children below than 5 years old, with 52 cases over 1 million. And the overall mortality is 30%. It's quite high. Okay. So the next one is the etiology. Mostly is unknown, but there's some associated factors such as chromosomal abnormalities that has been found in various benign and malignant tumors. And there's also genetic factors where it actually only plays minor roles, but has proven to increase the incidence by 5%. And for examples is the neurofibromatosis, which is an autosomal dominant syndrome. And other than that, cranial exposure to radiation also increase the incidence of brain tumor. Okay, the next one is the differences between adult and pediatric tumors. So the first one is most common types of childhood brain tumors are not the same as the adult. As most childhood brain tumors is a primary brain tumors, while the adult is mostly is cerebellar metastasis. And most of the common tumor in children is actually very rare in adult, which is less than 1%. The next one is childhood brain tumors are less likely to change from low grade to high grade, and the brain tumors for childhood also bring different symptoms where it is more to developmental and growth symptoms. And the next one is children often have better prognosis compared to adults with similar cases. And the last one is treatment for childhood brain tumors usually differs from the adults. Okay. So this is the WHO classification
The
of
difference is the site of the tumor, isn't it? The site of the brain tumor can be divided into supratentorial and infratentorial.
infratentorial.
So how is it different from the adult one?
Most of children is supratentorial.
Wrong. Most children is infratentorial. Adult is more supratentorial. 60% in adult supratentorial. In children, 60% are infratentorial.
Okay, sorry. So okay. This is the WHO classification where actually there's about 120 types. So I'm only going to focus on the 5 examples that are most common in children. Which is the first one is astrocytoma, which is about 40% of cases. So it is most common pediatric brain tumor. It can be benign to highly malignant, but mostly it is benign, and it is origin from astrocyte, which you can see here. Okay. Okay, and then this is the grading according to WHO, where the pilocytic astrocytoma is the grade 1 and the most common, and for the grade 4 for the GBM is the least common and has and because of it is the grade 4, it has the least and worst prognosis.
It is not called GBM anymore now. It's just called glioblastoma. Multiforme, the name multiforme has been dropped. So just glioblastoma. Yeah. So that's very poor prognosis, very aggressive tumor.
Okay. So next one is medulloblastoma, which is about 20% of the cases. It is one of the embryonal tumors, which is most common, which is 90% in the embryonal tumors. It is predominant in males aged from 5 to 7 and arise in the midline of posterior fossa. Okay, and it is have up to 20% of spinal metastasis and have poor prognosis in infants, and that's why, and because of that, it has WHO grade 4. Okay. Okay, so
why is it poor prognosis in infant?
Because the cellular activity is most aggressive.
One important reason is because you cannot deliver adequate treatment, because one of the treatment for medulloblastoma, you require craniospinal radiation. You have to radiate the whole cranium with a boost in the medulloblastoma itself and then the spine also. And if the child is less than 3 years old, you cannot give craniospinal radiation because it can cause a lot of side effects. It's just like frying the brain. Okay, the patient will grow up not very clever, neurocognitive function may be affected, the patient may be short, the pituitary tumor, the pituitary gland may be affected. So usually patient with brain tumor, medulloblastoma in children less than 5 years old, you cannot give radiotherapy, yeah, because of the severe side effect, and because of that, there is one reason why prognosis is poor.
Okay, so the next one is this is just some illustration, and next one is ependymoma, which is about 8%.
So why don't you just keep that one? We're going to stay until 6 o'clock. Don't worry.
Oh, okay.
Can you go back? The cartoon.
Okay. So this is the illustration of what.
Interesting picture, isn't it? Yeah.
Yes. So you can see this is most common malignant brain tumor in children. Because astrocytoma is actually most common of the benign. This is the presentation where I will talk about later, and also the diagnosis, and also this is about the pathophysiology, where the tumor compress the fourth ventricle and it can cause hydrocephalus.
So why not talk about later? Talk about now, lah. They may have signs and symptoms of increased intracranial pressure, headache, vomiting, yeah, visual disturbances. And then, because usually it affects the cerebellum, so they have ataxia, okay? Ataxia, and they have fits as well. Any lesion in the brain can cause fits. And then because this part of the brain is very narrow. Infratemporal is very narrow. So any growth at all press on the flow of the CSF. Whereas if it is supratentorial, it does not press on the flow of the CSF very easily. Yeah. But this one, because the area is small, any tumor can press, so we can get the present with hydrocephalus, common presentation. Yeah. So presentation of hydrocephalus, they have squint, for example, as part of hydrocephalus. So this is the presentation of medulloblastoma. Yeah. Okay. Next.
So next one is ependymoma, where it is one of type of ependymal tumors. And from the name, we know it's from ependymal lining of ventricular system. And the mean age is 6 years old. And all of the tumors are told before is from posterior fossa. And in MRI, in MRI investigation, it shows a well circumscribed tumor, but with a variable and complex pattern. And it is rarely metastasized, and the grade is grade 2. Okay, next one is brainstem glioma, which is for about 6%. The most common location is in pontine, and it has 4 types, which is focal, dorsally exophytic, cervicomedullary, and diffuse extrinsic. So for this focal and dorsally exophytic, it is low grade, and it is slow growing tumor and has better prognosis compared to diffuse intrinsic, which is high grade and a very poor prognosis.
Why poor prognosis?
Because it can diffuse to other part of the brain.
Because this is in the pond. And one of the conditions for the tumor to be curable is you have to remove it. You have to excise it. If it is in the pond and if it is diffuse, infiltrating, you cannot move it because ponds is where the important areas are, isn't it?
Yes.
Yeah. So you cannot do surgery. So you cannot do surgery. And if they have brainstem diffuse pontine glioma, usually they will die within 6 months. There's nothing you can do. You give treatment or so, it will not respond very well. Yeah, because surgery is not done. Focal one, okay, because it's not diffuse, sometimes it is easy. You can still do surgery if you're a good surgeon. So that's why there's better prognosis. And it is low grade as well. So it grows very slowly, so very small, you can remove it. Yeah, okay.
So the last one is craniopharyngioma, which is a developmental tumor. It is origin from squamous remnant of Rectipoche, and it is locally invasive but very minimal, and the growth very slow in suprasellar region, and that's why it's WHO grade 1. Okay.
So usually this is treated by the endocrine surgeon because usually they come with growth hormone deficiency. Yeah. And
Yes,
they may come with some visual, yes. So more of pituitary. And does not require chemotherapy. It is surgery or radiation. Next.
Okay. So the next one is the presentation where the middle one is for all ages, and this one is for adolescent or children, and the baby one is for infants presentation. So for all ages, you can see that the patient can have persistent or recurrent vomiting, problems in coordination, behavioral changes, abnormal eye movement, seizures without fever, because with fever it is we are more prone to infections. Next one is abnormal head position, which is wry neck, healthy or persistent stiff neck. And last one is raised intracranial pressure. So for the adolescent, the children might have persistent or recurrent headache and blurred double vision. They will also present with lethargy and deteriorating school performance. They also be delayed puberty and slow growth. And for the infants, the development will be delayed and or regress. There will be increased head circumference progressively, and you can see separation of the sutures, bulging fontanelle, and also the infants may appear lethargy. So from this, you can see this is separation of the suture. You can see this lambdoid suture, you can see here, and this is bulging fontanelle, and this is wry neck or abnormal hip position. Okay, so this is the presentation based on the part that is affected, which is for the supratentorial or cortex. The patient may have seizures, hemiplegia, or focal neurological signs such as weakness of left arm or right leg, and also paralysis or plegia. And the next one is midline, which is the patient may present with visual field loss or pituitary failure. And the next one is brainstem. The patient might present with cranial nerve defects such as the sixth cranial nerve, pyramidal tract signs such as hyperflexia and Babinski sign positive, and cerebellar signs such as ataxia. And the last one is cerebellar. If it is affected or the tumor is there, so the patient may present with ataxia, coordination difficulties, and also abnormal eyes movement. Okay, so next one is the investigation. So the standard investigation or imaging for brain tumor is an MRI. So it can be with or without gadolinium, which with gadolinium will increase the it will be more detailed, and it is better than CT scan because it is more detailed. Okay, so for the CSF examination, it is required for complete staging, but for certain cases such as increased intracranial pressure, it is contraindicated. And for CSF examination, they will be using serum beta human gonadotropin and also alpha fetoprotein. And the last one is magnetic resonance spectroscopy, which is non-invasive and also ionizing radiation free. And it is for to study metabolic change of the tumor. And it can also use as a follow-up and distinguish between the recurrent tumor or from radiation necrosis.
So MRI is better than CT scan, like you say, because it's more detailed. And usually you do, when you do CT scan, any brain tumor, you do CT scan of the brain and the spine as well, not just the brain alone, because it can metastasize to the spine. So this is called dot metastasis, because the tumor is brain tumor in the brain, suddenly you see one small dot on one part of the spine, as if something has dropped from the brain, go to the spine. So this is called drop metastasis. Sometimes you don't see drop metastasis in the spine, but when you do the CSF, you see cancer cells in the CSF, but the CSF has not stopped on the spine and has not caused any growth on the spine, which is visible by X-ray. So that is a bad prognostic factor as well. If there is lesion in the spine, if there is cancer cells in the CSF, then it is bad prognostic factor. Yeah. What you mentioned about just now, beta ICG and alpha fetoprotein?
Yes, the serum use.
What's that for? You mentioned that you want to do beta ICG.
For germ cell tumors.
Okay, because germ cell tumor can occur in the brain as well. Okay, germ cell tumor can occur in the ovary, can occur in the testes where there are germ cells, but it can occur in the brain as well. Yeah, so especially if the lesion is in the midline, not at the side, there it's a midline, and then you can you should suspect that could be germ cell tumor. And in germ cell tumor, the serum beta ICG or serum alpha fetoprotein can be increased, and especially the CSF can be increased. So if you were to do that, okay, midline, and then there is no increase in intracranial pressure, you do CSF alpha fetoprotein or beta ICG, and it is increased, there is no need for you to call the neurosurgeon and do the biopsy. You can start treatment straight away. And germ cell tumor is very sensitive to chemotherapy. They need not do surgery. So even if you don't have a neurosurgeon, yeah, if it is positive for beta ICG or alpha fetoprotein, you give chemotherapy, and after chemotherapy, you repeat the scan again. If there is residual disease, then only you go in and remove it. Sometimes it disappears without any surgery. All right.
Thank you, Prof.
Okay, next.
Okay. The next one is for grading. Basically, to some.
Okay, this
summarize,
is histology. I think there is no need for you to know in detail. Yeah.
Okay. So in staging, because there is in stage which is tumor node metastasis, but the size of tumor is less relevant compared to the and also the histology. So that's why there's no.
Sorry, what were we saying? Can you repeat that?
Staging in brain tumor, TNM in staging is because the tumor size is less compared to the histology and also the location of the tumor itself. So brain has no lymphatic to.
Yeah, yes, okay.
This one is, so this is the examples for osteocytoma and others. And for grade 3, you can see there's anaplastic. Okay. So the next one is management. Okay, the first one is surgery, where it is usually is used as the first treatment and aim to treat the and also be aimed to treat hydrocephalus. And from the surgery, it can also provide tissue diagnosis. Okay, so for radiation therapy, it is usually combined with chemotherapy, and as similar as chemotherapy is to shrink tumor and also to treat cancer that cannot be removed by surgery, such as cervicomedullary and also the diffuse tumor that has been mentioned before. And also,
so even if the whole tumor can be removed, okay, for example, medulloblastoma, you remove and then you still have to give radiation, right? Because there may be some microscopic residual which cannot be seen on MRI. So you may still have to give radiation.
Okay, so for chemotherapy, and also, it is also to shrink the cancer cells and to prevent the cancer from spreading, and also to relieve symptoms of the cancer, to relieve symptoms that the cancer may be caused. And the last one is medicine, basically is to treat the symptoms, which is for corticosteroid and diuretics is to reduce brain swelling, and anticonvulsant is to reduce or prevent seizures, and for the pain medicine is such as analgesic is to release pain.
So management, in summary, surgery is needed in all except for germ cell tumor. Yeah, maybe don't need surgery. Radiation, okay, maybe needed in many, but usually it is avoided in children less than 3 years old to prevent damage. Yeah, but certain tumor, you require only focal radiation. That means just at the tumor alone. So that is less damaging to the patient. But certain tumor, like expansive malignant one, medulloblastoma, you need the whole brain to be irradiated. So less than 3 years old, usually it is not recommended. Chemotherapy is in all patients to give a chemotherapy. And of course, supportive treatment, all these diuretics and so on. Yeah.
So for the patient, the parents might want if the patient is old enough to join cancer support group, or the parents want to join cancer support group to share experience and problems. Okay, the next one is outcome. So for the outcome, 5 years overall survival rate for CNS tumor is about 50 to 60%, and the outcome is better for younger patient, but it is for younger patient is they have higher risk to develop complication, and the fast-growing tumors are more likely to reoccur after the treatment. And as you can see, the glioblastoma multiforme is the 5-year survival rate is 0 to 5%, is very low, and astrocytoma is 90%, which is has the higher has a good prognosis compared to this.
Just now you mentioned in medulloblastoma, for example, the younger the patient, the poorer prognosis. And now you see the outcome is better for younger patient. So you are contradicting yourself. So which one is correct now? Generally, for the malignant one, is poorer in younger patients, as far as I know. Yeah, because you are not able to give radiotherapy. But for the more benign, low-grade one, okay, younger patient have better prognosis. Okay.
So next one is the prognosis factors, which is first one is you know the type or origin of the tumor cells. Such as I've mentioned, some of the tumor or type of tumors have better prognosis compared to the others. And the second one is grade, according to the 4-grade system, where low grade has better prognosis and high grade has worse prognosis. And the third one is location and size, where it affects the treatment and also affect function of the brain tissue.
Yeah, like we mentioned just now, if it is pontine glioma, for example, even though glioma is low-grade tumor, yeah, but because of the location, that become very poor prognosis. So the type of the tumor, grade, and the location. Yeah, all right.
Some other factors such as specific gene mutation, metastasized tumor, but it's very rare in children, and also child's age and functional abilities.
Metastasized to other part of the brain, yes, very rare, but metastasis to the spine is quite common. Yeah, in the malignant one like medulloblastoma. Beyond the CNS, outside the brain and spine, it is not common. I've not seen any patient with brain tumor gone to other parts of the body, to the bone marrow, to the lungs, or anywhere. So usually it remains inside there, because of the blood-brain barrier doesn't go up.
Okay, and the last one is the late effects, where it is due to the treatment. First one, the patient might have neurological effects such as developmental delays and also focal-motor and sensory abnormalities. And then for neuropsychological effects, the patient might have behavioral changes, such like we all know. The patient is children, so they might spend more time. They are going to spend more time in hospital, so there will be some effects because of that. And next one is education, where the patient might have learning disabilities such as short-term memory. And the last one is endocrine system effects, where the patient can have hypothyroidism, delay or absence puberty, and also fertility problem.
Okay, so these are mainly effect of treatment, right? Endocrine effect of treatment because of radiation. Education, again, because of radiation. Neurological can be because of the tumor itself, can be because of the surgery. Yeah?
Yeah.
And neuropsychological, any patient with any cancer can have neuropsychological effect.
Okay, that's all from me. This is my references.
That's all. Okay.
Okay.
All right.
Okay, that's
all. Good references around. So, any questions? If there are no questions, then thank you very much. Any questions you can send by WhatsApp, and then I can try and answer the question, or you can ask next Tuesday, Wednesday, isn't it? We meet again. Wednesday? Another seminar?
Yes, doctor. Right? On Wednesday evening.
So there's going to be another 5 speakers for another 3 hours. Yes?
Wait, let me check first.
IUM give me one topic, 3 hours, and they pay per topic, RM100 per topic. So kalau anemia, kalau hematological, RM100 ke, walaupun 3 jam. RM30 sejam. Sian.
There's also 5 people, Prof.
5 people also. Let's make it 5 hours, okay? 1 hour. Boleh? Okay, try and not have more than 20 slides. Yeah? Kalau tidak, too many and too long. My voice pun dah affected already. Cannot talk already anymore. So far, any questions? So you must understand why pediatric cancer is very important, even though it is less than 5% of all cancers. Yeah, because it is the commonest disease cause of death in children. Yeah? All other diseases are becoming more and more treatable now. And the prognosis of childhood cancer overall is about 80% now, overall in best centers. The worst one, the bad players, the bad actors, number one is the brain tumor and neuroblastoma. The others are quite good, yeah? More than 70%, the others, but neuroblastoma as well as brain tumor, okay? Some of them, the chances of cure is only about 60-50% only. And you must remember the treatment is multimodal, multidisciplinary, multi-drugs chemotherapy, multidisciplinary, okay, mainly 3, radiotherapy, chemotherapy, and surgery. And in chemotherapy, some of the advances is bone marrow transplant or hematopoietic stem cell transplant. Yeah, for cancer especially if it is relapse. So it is used for leukemia, high-risk leukemia, to replace the diseased marrow. In solid tumors, you do bone marrow transplant or hematopoietic stem cell transplant, not because the marrow is diseased, but because you want to give high-dose chemotherapy. To make it effective, you give high-dose chemotherapy. When you give high-dose chemotherapy, there is bone marrow suppression. So you put back the marrow. So usually it is autologous transplant. Patient with medulloblastoma, for example, very young, you cannot give radiotherapy. So to improve the cure, you have to give very high-dose chemotherapy. And this causes their bone marrow to be suppressed. So before you give high-dose chemotherapy, you harvest their own bone marrow, patient's own bone marrow, then you give high-dose chemotherapy, and then you put back the marrow. Yeah, so this is called autologous stem cell, hematopoietic stem cell rescue. You rescue the bone marrow so that high-dose chemotherapy can be given without fatal side effects. And you want to give high-dose chemotherapy to improve the survival, to improve the cure. Advances in chemotherapy include targeted chemotherapy. This is using monoclonal antibodies, using growth factors, anti-growth factors, and all that. But if you are interested, go and read about it. But this is more of postgraduate. Yeah, targeted chemotherapy. That means you kill the cancer cells only. You don't kill all the other cells. You don't kill the normal cells. So it is supposed to have less side effects. Yeah, for example, targeted therapy is patient with leukemia with 922 translocation. So you can give targeted chemotherapy which target to the protein product of the 922 translocation against the tyrosine kinase. Okay, all that is postgraduate. And cancer, you must remember what is the definition of cure. And late effects occur even after the patient is cured. In US, for example, if they know that you have had cancer, even though you have been cured of cancer 5 years ago, 10 years ago, it may be difficult for you to get insurance, health insurance. Yeah, because they know that there is chances of getting second cancer and there is other morbidities as well. So usually you don't, very difficult to get insurance. This is because of late effects. And molecular genetics is playing an important role now. Yeah, with molecular genetics, you can tell the prognosis. And with molecular genetics, you can find what is the genetic abnormalities and try to find the target, yeah, against these genetic abnormalities. So targeted therapy. Okay, any questions? If there is none, then all the best. See you again on Wednesday, inshallah. Okay.
Thank you, Prof.
Thank you, Prof. Thank you, Prof.
What do I do with this? Send to the assessment.
Send to the department.
Okay. All right. So, okay, Assalamualaikum.
Thank you so much, Prof.
Thank you,
so
Prof.
much.
Rest
Thank you,
well.
Prof. Thank you, Prof.